I'll just give it another 10 seconds for people to take their seats. Wel, bore da, a chroeso cynnes iawn I drydydd symposiwm ATiC. Good morning and a very warm welcome to the third ATiC Symposium, Catalyse 2023, co-creating the future of health and technology. I'm Professor Ymunwch, Director and Founder of ATiC, the Assistive Technologies Innovation Centre, here at the University of Wales Trinity Saint David. So I'm the warm-up act today, okay, so you'll be pleased to know. There's some practical information, first of all. We're not expecting any fire alarm tests. If the alarm does go off, we need to make our way to the nearest exit, which is going to be the way you came in and down the stairs, or over the trip hazard here, over the wires and out the door, and then make your way towards the muster point, which is at the front of the building. For those of you trying to access Wi-Fi, if you haven't already read the guidance notes, if you look for UWTSD guest wireless network, you just select UWTSD guest, no security key required. You'll be redirected to a registration page, pop your details in, reason for access, Swiss bank account number, and make your deposit, and then you'll be on the Wi-Fi. Yn anffodus, ni allwn ddarpru, here we go, cyfieithu ar y pryd heddiw. We don't have any simultaneous translation today, but the booklet or the program for the day is bilingual, so you should be able to follow in the language of your choice. Now, we are recording sessions today, so again, if you don't wish to be photographed or don't wish to be recorded, then please make that clear, particularly if you're on the witness protection program. Okay, it could be a bit embarrassing for you. But no, seriously, if you don't want to be recorded in terms of in the room, please let the photographers know. Well then, before I introduce our Vice-Chancellor, I'd like to say a few words, and I'd like to take a few moments, really, to tell you a story, the genesis of which goes back to around 2008, when a group of product designers, academics and staff began working closely with the charity Cerebra to design products to help children with life-limiting conditions, particularly neurological conditions, and to improve the quality of life. Out of that initial cluster of activity was formed the Cerebra Innovation Centre, which has turned into a successful 15+ years partnership, resulting in hundreds, if not thousands, of children in the UK and around the world receiving life-enhancing interventions created by the CIC team, often with the collaboration of design students and academic staff. I mention that because in the establishment of the Cerebral Innovation Centre, we find the seed which was planted, which would eventually become the Assistive Technologies Innovation Centre, or ATiC. Back in 2014, ATiC came together as an informal cluster of academics, designers, and PhD researchers working on initially student projects linked with maybe live projects from industry or health boards, some of which progressed on to become commercial R&D projects. And as a team at that point, we also formed a relationship with Hywel Health Board. I think I've been on the R&D committee now for longer than I care to remember, but quite a long time. But the key turning point came in 2018 with the launch of the Accelerate programme, led by the Life Science Hub Wales, with £24 million of funding from Welsh Government and the European Regional Development Fund. Accelerate brought together the medical schools in Cardiff and Swansea with an unlikely partner in the form of ATiC at UWTSD's Swansea College of Art. But with this unlikely partner came a huge array of possibilities. ATiC quickly established itself as a valuable and dependable contributor to the programme by creating a bridge between the clinical innovators and product developers. Now, typically, collaborations between universities and industry in the life science and health spheres are seen as three-way partnerships. The ABC, if you like, academia, business, and clinicians. What ATiC has successfully done is to add the letter D to the formula for success. D for design thinking, bridging the gap between academic research, business opportunity, and clinical need. I'd go even further to say we've added an E to the equation, experience or user experience. Give us 20 years and we'll get to Z, okay? But the key thing is that we've been able to forge partnerships with life science sector, with health boards, with industry, to help bring that design thinking mentality and that user experience or usability engineering processes into the design of products designed to improve the health and well-being of the nation. Whether it be devices, systems, or spaces, ensuring that those in their design meet the fundamental needs of the users and also deliver sustainable and commercially viable solutions. So here we are, 15 years on from the creation of an idea which has come a long way, an idea which has overcome numerous challenges, funding, credibility, we need to establish ourselves, Brexit, even a pandemic. A messy journey, but one which I'm sure will be familiar to many of you, whether you work in the health sector or work in the commercial business and manufacturing sectors. If you've committed yourself to the pursuit of innovation, to enterprise, to making a difference in people's health and well-being, it's often a very messy process. Innovation isn't a straight line. Somebody described innovation not as a pathway, but as a jacuzzi a few weeks ago at a meeting I was at. Lots of ideas bubbling together, and somehow out of it, some good will come. So I'd like to thank you for joining us this morning, and I hope that we will all learn something new today as we each take another step on our own personal innovation journey. So diolch yn fawr, thank you very much, and I would like to hand over to our new Vice-Chancellor, Professor Elwyn Evans, KC.
Thank you very, very much. Well, there's a thought. Welcome to the jacuzzi this morning. Croeso cynnes iawn I chi gyd. Falch iawn o'ch gweld chi. I see the usual pattern has been well followed. Everyone sitting in the back. But I'm sure there will be opportunities during the course of the day for you to come further forward. Diolch yn fawr iawn I chi am ymuno efo ni. I've been given very strict instructions this morning. I have a terrible habit of wandering around when I'm talking, and I don't like microphones. But you'll see, I'm having a thumbs up over there. I've been told, as this is being live streamed, that please will I stick to the microphone. And probably Ian would say stick to a script. So here I am on my 8th week as Vice-Chancellor of the University of Wales Trinity Saint David. And it is a real, genuine pleasure to be sharing today with you. Lots of people ask, what does a Vice-Chancellor do? Haven't quite worked it out yet. But one of the things that certainly is a real privilege is being able to be involved in events such as today. Because if we are not in the business of changing lives, then actually we're not doing the job right, are we? And this is the sort of work which fundamentally is at the heart of what we need to do as a significant partner with a significant agenda at a time when it is incredibly important that we maximize those relationships and those opportunities. And so it is a genuine pleasure. The words we overuse, aren't they? Pleasure, privilege, but it is. It absolutely is. and you will know that ATiC and the work that ATiC does is one of the very many things that we are very, very proud of as a university. And this event is held in collaboration. Again, and we were talking a few minutes ago, it's one of the really important words that we are using as a sector, as a country at the moment: collaboration. For me, what we need to do isn't just to use the word, but to absolutely demonstrate and evidence what we are doing is genuinely collaborative. We can't solve the problems of the region of Wales, the country, more broadly on our own. It is only through genuine, heartfelt, profound, meaningful collaboration that we can start to progress and build on the successes that have already been achieved. And so we're collaborating today, and I say it with enormous pride, with Hywel University Health Board and its TriTech Institute. Of course, also collaborating with a wealth of other organizations, bodies, and people. I'm going to name some names, but please, in doing that, I am not being in any way exclusive of anyone. It is a real joy to see so many here, and of course those who are joining us online, and everyone is welcome. But some names, if I may, because they will reflect the programme that we will be following during the course of today. To our keynote speaker, Dr. Rob Orford, the Chief Scientific Advisor for Health for Welsh Government. You are very welcome, and we are very much looking forward to your keynote speech. I'm delighted to welcome Professor Phil Clur, and I will be handing over to him very shortly now, the Medical Director and Deputy Chief Executive Officer of Hywel University Health Board, and also delighted to welcome Professor Chris Hopkins, Director of the TriTech Institute, key partners with us, with ATiC. There are 4 themes. I'm sure you will have read the programme, but just to remind you, 4 key themes in our sessions today, including co-creation and partnerships, immersive technology, medical technology, digital technology, and big data, all incredibly relevant key topics. And it's a fabulous programme that's ahead of us today. So, welcome to you, invited speakers from Wales's health and higher education sector, from within the United Kingdom, and indeed internationally, with some of the enterprises here today, including Bloom Standard from the US and Cyberdyne from Japan. Welcome. I can't emphasize enough the pride we take in our partnerships, in our relationships with health boards across Wales, and one, of course, of the bodies we are delighted to welcome and work with, Digital Health and Care Wales, a national organisation building and designing digital services for health and care in Wales. Digital Health Ecosystem Wales, a collaboration between Life Sciences Hub Wales and Digital Health and Care Wales. Lots of names, but the secret is in bringing everyone together, the working together. And so that is a wonderful array of industry, clinicians, policymakers, academics, innovators, and even funders to create an environment of digital innovation in Welsh healthcare. So a fabulous opportunity today to showcase how collaboration between academia the NHS, industry, deliver real benefits, real outcomes. And I started off by saying the real privilege of my role as a Vice-Chancellor is to support and ensure that the academics within our university are working with academics across the sector, but also with all of you. And why are we doing it? Yes, because it's very nice to meet and talk and network, but it's wonderful to have the opportunity of changing lives as well. So thank you very much, enjoy the day, and I look forward to ensuring that at least we, as a university, will continue to demonstrate, as ATiC has done over the years, genuine collaboration and genuine delivery. Diolch o galon i chi gyd. Mwynhewch y diwrnod.
Well, Bwrdd i chi gyd. Good morning, everyone. I'm Phil Claw, Medical Director, Deputy Chief Executive Hywel Dda, University Health Board. And I think I also, therefore, need to stand by the microphone and can't walk about, is my habit. So look, it's amazing to join you here and to be in the jacuzzi with you, apparently. So thank you, Ian, for that image. Trying to imagine that right now. So look, I will also try and stick to the brief. One of the things I think I'd like to do is just to reflect on health and care at the moment. And when you think about the planning that went into place when we were dealing with the pandemic, actually that was relatively simple compared to managing the aftermath, which is a huge, huge challenge everywhere across the world, not just here. And at the moment, it touches everybody's lives, doesn't it? There's people waiting for procedures, tests, assessments. GP surgeries are full everywhere, not just in West Wales, everywhere. Hospitals are full, social services are struggling. So it's a really big challenge that we all face. And I suppose that sounds significant, but then if we look forward to a sort of 20-year horizon, what will we see over the next 20 years? And apologies for giving a rather sober view at the start, but I'll try and lighten it up later. But at 20 years' time, in fact, 2044, it's predicted that we will see peak death. I know that tends to get people's attention, but it's at that point that it's predicted we'll see the most people dying in the UK, and that's because of the sort of baby boomer population. Peak mortality is probably a sort of more fair word to use. But that's really significant, not just because there'll be the most people dying, but also because we'll see the largest number of older population about and the smallest number of younger population about. So the demographic will be a proper triangle at that point with a really large older population. And that's not only a problem because there won't be enough people to care, because at the moment we've already got challenges, haven't we, with carers in society. So really have an even bigger problem with numbers of people to care. But there'll also be a challenge around a smaller number of people relatively who are economically active. Now, if we couple that with the challenge around climate in 2044, how many people make estimations about how many bony fish will we see in the ocean, those sort of challenges, plus what will tech and digital look like in 20 years' time? It's difficult to predict that in 5 years' time. Actually, there's a huge amount of change going to happen to our society. And what I feel is, one option is to sort of meander our way towards that over the next 20 years. The other option we have, and I feel we're doing that together, is take some positive, energetic steps towards tackling those real societal challenges that we're going to face. And that 2044 isn't something that's going to happen in 2044. Suddenly, it's there. It's a ramp towards 2044. And in that time, we'll see rises in long-term conditions, and we've seen that prediction in the recent Chief Scientific Officer's report. There'll be higher rates of cancer and dementia. So there's all sorts of things that we will need to face as a society, not just the health service and not just social care. And as I'll talk about in a minute, that isn't going to be solved just by a medical model of health that we have at the moment. If that's what we rely on, then we're going to need to build a lot more hospitals. And of course, we know that can't be the answer, because for one thing, we won't be able to staff them. So there's got to be something else that we need to do. So I think we need to harness, as I feel we are, the technological and social innovations that are within healthcare, but also within other industries. I think our work with UWTSD is an exemplar in how we bring together the university sector, industry sector, and healthcare sector in facing these real challenges and coming up with solutions. So Leighton Phillips, I need to credit him with this because it wasn't my thing. He reminded me of an African proverb, which I think is really apt for us when we're thinking about this. It is, travel far by traveling together, travel fast by traveling alone. So when I look about me in my daily life, I see a lot of people traveling fast, and most of them are traveling fast around a hamster wheel, doing exactly the same thing, rushing round and round and round. And that clearly is not going to solve the challenges we face now, let alone in the future. So I feel we are joining up our appetite for innovation in healthcare with UWTSD's thirst for application of evidence and insight to real-world application. As your new Vice-Chancellor said, one of your key aims is to demonstrate genuine impact on people's lives. And I think, we have a real opportunity to do that. So look, our collaboration, because, we use that word, as you said, Vice-Chancellor, we use that, it's bandied about everywhere. But I think we are doing this in practice. Through TriTech, I see absolute evidence of that. We've done that through bringing together our teams, our structures, and our processes, and aligning them together. And it's been really powerful. So it's important, of course, that we celebrate some of the fruits of this collaboration. And we'll see today, through all of the presentations of the projects, evidence of real innovation and impact. I think one of the challenges, though, today, if we test ourselves a bit further, might be to consider how we might look at social innovation. Because if you look at healthcare, it's only responsible for 15% of people's health and well-being. The other 85% of people's health and well-being is built on by the social determinants of health. And health and well-being tends to be created within communities. So I think the challenge for us over the next 20 years is to consider how we work on social innovation. And of course, tech can be applied to those communities, but more and more I think that's where we'll need to be. So look, I'm really looking forward to today and hearing more about the projects, and I'm really looking forward to growing our collaboration even further as we go forward. So look, thank you very much for inviting me here, and I think I'm handing over to Rob Orford. Welcome. Thank you.
I can see you all at the back now. Bwrdd, and thank you ever so much for the very kind invite to come and speak to you today. I was invited last year to come and I couldn't. Unfortunately, I was waylaid by preparing for the public inquiry, and I've been waylaid ever since. I finished my last statement on Saturday morning, so I'm free again. Whilst I've been looking backwards, my group in Welsh Government, which is called Science Evidence Advice, have been looking forwards, and I'll touch upon some of the areas that Phil introduced. They're worth saying twice. In this reflective period that I've had of thinking in much slower time in forensic detail about our actions and activities during the pandemic, it's been really useful to think about what's coming and what we've seen. So one of the first questions that we were asked in those early months of 2020 was, how big would that wave be? When would it arrive? When would we see peak demand? When would we see peak deaths? And in those first projections that were absolutely woeful, it suggested as a reasonable case there would be 28,000 deaths in Wales in that first wave. And the things that we had available to us were rather blunt tools that caused significant harm, but they would take pressure off the NHS and they would protect people in Wales. And for those measures to work, we absolutely needed the collective actions of the whole of the public and whole of society. And we did that because we thought it was important to protect the most vulnerable in society. We did it to protect our loved ones, and we did it to protect the NHS. We think health is important, and we'd forgo our liberties to protect others. So those blunt tools that were brought to bear on the population were soon outcompeted by tools and interventions that caused more balance, that created less harm. Lateral flow testing, therapeutics, and then vaccines. They were very much science-led, and they were very much evidence-informed. And we saw that necessity is the mother of invention and innovation. So I think today and tomorrow we're in a very similar position. Not that we're facing an epidemic. COVID is still here. It's not gone away, and it will invariably come back in different guises. But now we're facing a syndemic. We're facing a number of challenges that are combining and presenting significant harm on our population and our health service. So very recently, my team, while I was busy with my pen, my quill and my parchment in my loft, wrote a paper looking at what the future might look like in Wales, asking what the health of people in Wales will look like in 10 or more years' time, people that we work with, people that we live with, our loved ones. And they asked, what would this do to our health service when it turns 85 years old? And we were asked this question so government could see whether its policies were in the right places, whether our assets in the NHS and social care were aligned for what might be coming. And I think you could all take a very well-educated guess of what's coming. You've just heard from Phil. It says we live in an aging population, and it says the prevalence of various conditions, long-term conditions, will increase. And there are conditions like dementia, diabetes, cancer, musculoskeletal conditions that are significant. And some of those conditions, like cancers and dementia, are a consequence of us living older. Fewer people are dying of communicable diseases. But we know that there'll be an increase of people living with 2 or more long-term conditions in this period. And there'll be a doubling of people living with 4 or more complex conditions. And many of those will have mental health issues. And for people with 4 or more complex comorbidities, they will go to an outpatient's appointment about once a month, which is a significant burden on the NHS. From the projections, as we did in COVID, it looks like some of the diseases will increase more swiftly, faster than the age of the population. Conditions like dementia, heart failure, osteoporosis, chronic heart disease, asthma, hypertension, anxiety disorders, and diabetes. Diabetes alone, it might increase by 22% to 260,000 people in Wales alone. And some of these increases are preventable. Obesity is projected to rise, and itself is a risk factor for many conditions like diabetes, dementia, and hypertension. We know that for every £1 that we invest in prevention, we get a £4 return and our £1 back. We know if we do this at a national level, we get a higher return again. We learned that in the pandemic. We learned that local interventions, whilst they were effective, they weren't as effective as national interventions. So we really need to think collectively. We know that people living in disadvantaged areas are more likely to have multiple conditions. And there's a stark difference in life expectancy between less affluent and more affluent areas, with people living on average 9 years less long. And in those same areas, people will live in ill health much longer, 22 years versus 13 years. So the evidence is telling us we have to invest in prevention, and that's very difficult with the challenges that we have today. And the evidence is telling us we need to address social inequalities and health inequalities. It says we have to diagnose earlier. It says we need to treat people as a whole person rather than a pathway, and we need to do more with people closer to them at home in the community. And none of this is new. This has been writ large by other organisations, Academy of Medical Sciences, the Health Foundation, the Bevan Commission. None of this is new. We also know that many people are out of work because of long-term conditions. That adds a sea anchor to our economy. It reduces our prosperity. It decreases our resilience to threats that come along, like pandemics and climate change. We know the workforce is ageing. We know people will need to be in the workforce for longer, so it has to be a really good place to work. And we know we're living through this technological age of precision medicine and AI and robotics and medtech. So what's the answer? And I'm hoping I'm going to hear from you today. My job and others in government are to create the policies to support the landscape, to create the environment for life sciences, for technology to prosper. Paul Nurse recently wrote a review of the RD&I infrastructure, and he said we have to focus the beam. We've got enormous activity, we've got enormous potential, we've got incredible strength in our universities, so we have to channel that on the problems that we have. We have a UK life science vision, and we've got missions where all of the research councils are coming together and saying, how can we address dementia? How do we go after cancer vaccines? How do we think about aging in a more sensible way? And there's a time for Wales to come together and go after that environment and work collectively and collaboratively. Lord O'Shaughnessy said recently, we need to do more commercial clinical trials. We need to work in trusted partnerships with NHS, with industry, with academia. We need to make clinical trials a standard of care because it improves outcomes. We have an innovation strategy in Wales. We're developing a life science plan that sits beneath that. We have a healthier Wales that articulates all of these challenges, and that was written in 2018. And we have a Wellbeing of Future Generations Act. So we're committed to think about the future and not discounting it. So from my perspective, I think we have the policy landscape, we have the opportunities, and in Wales we need to brace those opportunities by working collectively. When you think about those challenges, you can kind of feel hopeless that this is a foregone conclusion. But we have changed health trends in the past, whether maternal mortality, childhood illnesses, or communicable diseases through the introduction of vaccines. I think what's different about this syndemic is that we will all need to work collectively. The NHS cannot take all of the burden itself. So we need to work collectively with the public, with charities, with industry, with academia. Everybody needs to work together on this collective idea of changing this trend. And I hope if we work collectively, we can show that getting older doesn't necessarily mean getting unwell. And I think that's really the challenge that we have. I hope you have a fantastic day today. It's a real privilege to be here, and it's great to be at my loft. So thank you for your time.
huge thank you to our initial speakers, and thank you, Rob, and thank you, Phil, for kick-starting our day. We're moving through into session 1 now, and actually before we start session 1, I wonder if a couple of colleagues could maybe lower the blinds a little bit, because those of us sitting in the front row are getting rather hot at the minute. We just drop it down a bit. The sun's... The jacuzzi. Can somebody turn the jacuzzi down, please? And so, we're moving into session 1 now, which is co-creation and partnerships. We have 4 speakers: Professor Chris Hopkins, head of the TriTech Institute, and also key partner with us in ATiC. John Carrington, Chief Executive of NGPod Global Limited. Anna-Marie Saarinen, Chief Executive Officer and co-founder of Bloom Standard. And then, no name for speaker here, ATiC and NHS Wales Rehabilitation Engineering Services. Is that going to be Sean, I take it? Yeah, Sean. Yeah. So modest, he hasn't put his name on the brochure. So, I should say, actually, a bit of housekeeping as well. For those who need to take some Teams meetings or Zoom meetings through the day, we have some rooms available up on the second floor of the building. So if you see one of my colleagues at the reception desk, they can direct you to those rooms. So if you need a bit of peace and quiet to take a Teams meeting or whatever, there's a space for you to work upstairs. So then, first speaker, Professor Chris Hopkins. Where are you, Chris? Come forward, please. Come on down. Thank you, Chris.
I'm going to have to stick to the mic now. Good morning, everybody. First of all, thanks to our Vice-Chancellor, Hywel. Thanks to Ian, thanks to Phil, thanks to Rob. But in particular, thanks to all of the ATiC team. I normally make them stand up at this point and take a round of applause. I'm not going to do that, but I think we all need to remember what goes on behind the scenes, really, to pull an event like this together. So my thanks to you all. I've got a few roles. I've got 2 NHS roles. I work in Hywel University Health Board, and I also work I've just taken on a role up in North Wales within Betsy Cadwaladr University Health Board. But I'm also clinical director within the ATiC team within UWTSD as well. And that gives me a number of opportunities, really, to really forge these alliances and these partnerships. So I've got a bit of a random presentation for you today. I've got 2 parts to the presentation. I'm going to go back in history a little bit, first of all, just to sort of look at some of the themes around partnership and research and innovation. And then I'm going to share with you then a specific example of an AI model that we worked on in collaboration with a number of partners around prostate cancer. I hope this works. Okay, going back to 2022, we sadly lost Queen Elizabeth II during this year. And I am going to stay on piece today. I'm going to read from the notes, okay, because I normally tend to go off on all sorts of tangents. So we sadly lost Queen Elizabeth II during this year, but we also celebrated 70 years of her accession to the throne. Images in the media of the Queen in her younger days probably bring back flashbacks for those of us that are old enough of what the UK was like in the first half of the 20th century. But by any account, it was a period of astonishing change for the UK and for the world as a whole. I told you it was going to be random. Comparing life then and now, the presumption is all too powerful that progress is the assured course of human history. However, if we reach further back in time, we'll find that progress is in fact a rather young concept. People in the past thought of the body of human knowledge as somewhat contained, because indeed there was not much else to study at that particular time other than theology and metaphysics. But a monumental development in our Enlightenment was the opening up of nature as a field of study. The theory of evolution by natural selection was first formulated by Charles Darwin's book, which was published back in 1859. In his book, Darwin describes how organisms evolve over generations through the inheritance of physical or behavioral traits. Because nature does indeed operate according to constant laws, these laws can be known to us through measurement, mathematical description, logical reasoning, and empirical verification. What has become to be known as a scientific method gave both impetus and structure to our human curiosity. Nature became the subject in which new knowledge could be had, and the scientific method became the standard by which knowledge could be validated. Okay, first test of the day then. Easy one first of all. Who's the gentleman on the right-hand side? Show of hands. Einstein, wonderful. What about the gentleman on the left-hand side? Oh, there's a hand up. Faraday, Michael Faraday, indeed. So for the everyday person, science is somewhat obscure, and it can be quite baffling at times. But technological innovation became the means by which the everyday person gets to enjoy the new discoveries of science. We don't really need to understand Faraday's law or Maxwell's equations to enjoy the numerous electrical devices that are at our disposal, or the use of our mobile phones. And we don't really need to understand Einstein's general theory of relativity to be able to use our GPS devices. But it is by technology that science becomes tangible to the everyday person, and thus progress becomes practical to us all. And it was when society perceived the benefit of new knowledge that knowledge creation was transformed from being undertaken by isolated people working by themselves here and there to an institutionalized effort with colleagues working together. And this, I'd argue, was probably the very beginning of modern research. With innovation comes jobs and strength of the economy. And so tight is this linkage that there's now a new geography of jobs that is distinct from the former geography shaped by manufacturing and finance. We know that cities with strong research universities will be strong economic centres of the future. If the research function of the university produces innovation, it is the educational function of the university that produces the human talent that will sustain innovation as well as translate innovation into tangible benefits for society. Talent and innovation work in a virtuous cycle to support centres of economic strength. And the life science sector in Wales generated over 2.6 billion in turnover for the Welsh economy in 2020. That was up 12.1% from the previous year. Over 260 new businesses have launched in the Welsh life science sector since 2020, and the industry now employs over 12,500 people across Wales. And in terms of export, medicinal and pharmaceutical products were among the top 5 exports and have a yearly value of 1.1 billion. In November 2019, when the Royal College of Physicians published this document entitled Benefiting from the Research Effect, they suggested a number of ways that NHS trusts and UHBs can support staff to become more research active, and how this would benefit both patients, staff, and our communities. It showed that the involvement by staff in research can improve their morale, but can also help us with the recruitment and retention difficulties across Wales and across the UK. And for me, research is far more than just clinical trials. Anything that provides new knowledge and improves patient outcomes should be considered research, delivered by multidisciplinary teams. It ranges from discovery science to epidemiology through to robust evaluation. And as we enter a new era of digitization, we're already applying new learnings in key fields such as AI and big data to solve major challenges facing critical industries like healthcare and like energy. Innovations are not only the collection and analysis of patient imaging and the application of genomics, but also diverse physiological and molecular measurements in individuals at a level that's not previously been possible. How effectively society as a whole is able to capitalize on AI in health will depend in part on how well this data is integrated by our clinicians and communicated to the public. Ian will be pleased I put the innovation matrix on this one. So collaboration between health, industry, and academia is key. It's key to catalyse innovation and growth. While industry often focuses on addressing solutions that are of near-term commercial value, and academia and health focus on building new knowledge through research and imparting education to our students, the combination can yield an accelerated development of new breakthroughs. Industry partnerships are instrumental in advancing research and creating a skilled workforce. Industry gains work-ready talent with specialist knowledge and practical training, and universities and health benefit by having opportunities to work on relevant technologies and challenging problems. What is more expensive to society are the consequences of not supporting our universities, our industry partners, and our clinical teams. And here comes the preach. In a democratic society, governments come and go, and government funding priorities come and go. But an appropriately supported research and innovation culture endures. While our universities and health boards are being tossed to and fro through economic, financial pressures and changing policy, research and innovation serves as a ballast to give stability for our future, and more importantly, for our patients across Wales and across the UK. So for those that are not aware, the Innovation Matrix is being developed just over the bridge, and that will be an area where we can basically create this jacuzzi effect, let's say, where we all work together, health, academia, industry, to really work together on solving some of these complex problems. So, moving into specifics, this was a piece of work that we undertook over an 18-month period. It's a piece of work that, for me, exemplifies where partnerships can really support sort of the solutions around complex problems. So within this work, we examined the use of an AI model to support prostate cancer detection at that MRI stage. I put an example up here of the TriTech team. It's not just the TriTech team, it's academia, it's everybody we work with, really. But I'm very fortunate, we're very fortunate within Hywel to have a team like this, because if you look at the slide deck there, you'll see we have nurses, we have doctors, we have pharmacists, Dan will be speaking today, I have clinical scientists, engineers, researchers. All of these bring something different to the various projects and studies we work on. And then added to that, our academic colleagues and our industry partners all support and bring something different to this discussion. So, we know that 1 in 8 men across the UK will develop prostate cancer, and that risk increases, particularly from age 50 onwards. Men typically present with prostate sort of related symptoms to their GP, where initially they'll receive a PSA test, which is a prostate-specific antigen test. This is part of the agreed NICE pathway across the UK. If that test is elevated, they'll then be referred on to MP-MRI. So it's not just a standard MRI, this is multi-parametric MRI. And again, depending on the outcome of that MRI, they'll then be passed then for biopsy, which is considered really the gold standard for testing. However, there's a problem. There's a problem here, because all of the literature suggests that accuracy at the MRI stage is less than 50%. And on occasion, it can be as low as 30%. And there are a number of factors that cause this issue. Number one, the prostate as a gland is very difficult to interrogate, really, particularly at the early stages of cancer presentation. Added to that, we've got a shortage of radiologists across Wales. And on top of that, we've got a shortage of radiologists with a specific interest in prostate cancer. So we know there's a problem there. And what tends to happen is these patients, if there's a doubt at the MRI stage, these patients will be passed for biopsy, just to make sure we don't miss any potential cancers. But the biopsy presents additional risks for those individuals as well. So we had the opportunity of collaborating with a company called Gyd-greu to look at their GYVR-RDX model. Their initial results suggested 87% sensitivity and 67% specificity. But those results were obtained from various archived data banks across the world. What they didn't originate from was from actual clinical practice. And we know within a real-world clinical environment, MRI machines are different. We have different manufacturers. You have different strengths of MRI. You could have a 1.5T, you could have a 3T. You could even have, within Cardiff University, you could have a 7T MRI. But they're also configured differently. So we wanted to test and develop this AI model in a real-world clinical environment. Just to give you a sort of sample, really, when we do an evaluation, we follow a similar process to that what we'd follow really through a research study. So we applied inclusion and exclusion criteria, procedures are developed, data collection, we consider patient confidentiality to make sure that all of these images are anonymized before we sharing them with any industry partner. And we also undertook both quantitative and qualitative analysis during this study as well. And we also used the NICE meta tool. And the NICE meta tool allowed us to look at the evidence base surrounding this GYver RDX model to understand where they are and where they need to be then as they move forward. So just a sample on the screen now on the typical sort of inclusion-exclusion criteria. We only looked at patients between the ages of 50 and 75. We looked at a range of Likert scores. So when a patient presents at MRI, they'll be scored. So 1 will be cancer not likely, 5 will be cancer significantly likely. So we wanted a range of scores to include in the study there. And where do we get to? So over that 18-month period, after various iterations of relearning and sort of adapting the model, we achieved then 77% sensitivity, 65% specificity, and 69% accuracy overall. Now, a number of you would sit there and go, well, we need more. Really, in an ideal world, you'd want 90% or higher around your sensitivity or specificity figures. But if I refer you back to the original slide, where current accuracy is sitting at 50% or even low as 30%, there's something there that we could potentially use at this stage. We can't use it at present because it needs to go through the MHRA for regulatory approval. But what we do know is, as we start to use this as a tool and we feed more and more images through this model, then that AI algorithm will get better and better over time. So, we've already discussed the sensitivity and specificity, but the qualitative aspect is really important for me, particularly around AI. So we surveyed 15 of the multidisciplinary team involved in the urology pathway, and 11 of the 15 responded. All 11 of them had a positive opinion of the AI model, which is interesting because if I'd asked that question of radiologists 5 years ago, they feared AI because they felt that AI potentially would take their role in the future. But they all recognize now that AI is a tool to support their decision making, and they recognize the opportunity. So they all highlighted the fact that the AI model could have on patient safety, on patient outcomes, on teamwork, communication, and efficiency as well. Unfortunately, of the 20 patients we surveyed, only 3 of them responded. All 3 of them responded in a positive nature. But when we dug into, well, why? Why didn't the other 17 patients respond? It was because they didn't understand AI. They had no idea what AI was. The only appreciation they had of AI is what they see in the media, which is unfortunately quite negative in some respects at the moment when they talk about world domination and sort of, all this sort of thing. So there's some work. There's some work that we need to do there with our communities to raise awareness around artificial intelligence. And the value case, we undertook a health economic assessment of the model, and that came back with a potential cost saving for the NHS over the duration of that pathway. So, just to conclude, we found that the model could also integrate into our systems as well. Furthermore, engagements with the clinical teams and patients, as we said, there's a positive impression there. We're now working with GYver to support them through that regulatory approval process. The full evaluation, by the way, if you go onto the TriTech Institute website, the full evaluation is on the link there. So my thanks to you all for your time today. I hope the initial part of the presentation wasn't too random. I hope you've enjoyed the history lesson today, and I'm very happy to take any questions.
As ever, these events, everybody's a bit shy, so please grab hold of Chris over coffee. And as Chris has given me license now, if you haven't got your brochure for the Innovation Matrix. Pick it up off the back table, check us out on the website. There is space available. Not much, but there is space available if you fancy relocating your business into the heart of our SA1 Innovation Quarter. Well, our next speaker is John Carrington, Chief Executive Officer of NG Pod Global Limited. John.
Hello, good morning. Unlike everyone else that's spoken before, I'm not used to this, so please bear with me. And I'm really preaching to the converted. We're a room full of innovators. So what I'd like to talk to you today is about our experience, particularly of implementing innovation in a healthcare environment, which as a business that's been around for 10 years and just in the commercialization stage, it's quite important that you guys understand how difficult sometimes this can be. So how do we get from here? So this is the 1950s picture of the NHS. That actually could be my mother there because she was in the NHS at that particular time. To here, which is a modern day, blank screen, modern day ICU. So there's a very simple answer to this. We've also seen a significant increase in life expectancy over the last century. And there's a very straightforward answer to this. It's not the only answer, but it's a very significant part of it. It's innovation. Now, innovation on its own is great to have, but innovation without implementation is useless, it's worthless. So we are talking today about the implementation in healthcare. And innovation only happens if we have change. So this is really our view of how change is perceived. What is change? There's some nice definitions here, courtesy of AI, strangely enough, from Bing. So to make something different or to modify, to replace something with something else, newer or better. And again, newer or better equals innovation. So there's a clever chap called Tony Robbins. He's an American entrepreneur. He's a TED talker. He does blogs. He's a YouTuber. He's quite well known. He came up with a very simple equation, which is change happens when the pain of staying the same is greater than the pain of change. Now this is quite an interesting one. Pain is very subjective. Now pain is a feeling. It depends on the intensity of that pain, on how it makes us change. What are the consequences of that pain, and who is feeling? Am I feeling the pain, or is somebody else feeling that pain? Now, there's also another thing to be said that in terms of this is environment matters. Now, I've only been in the medtech industry for about 10 years. So before that, I've been in the toiletries and cosmetics industry, and the environment there is very, very different than the environment in healthcare. So I just want to do a very quick comparison between the two. So for consumer goods retailers, the customer has all the power. So they are very, very powerful. They dictate the terms. The profit margins for the suppliers are minimal, and the consumers have a choice of where to purchase. So there's a lot of difference between that and healthcare. So there's a constant downward price pressure. So retailers competing for market share, which drives extremely competitive supplier base. So the simple answer is, if you don't innovate, you do not survive. It's very, very simple. The innovators are the ones that progress. Everybody else just falls by the way, so either gets bought or basically they don't progress. In healthcare, it's very different. The customer, which is the patient, has very little power. As an individual, they have very little power themselves, and they're probably at the most vulnerable while they're sitting in a hospital bed waiting to be sorted out. We measure spend and how do we save money rather than profit, and how do we, so it's all about how we spend less. I mean, one of our customers, they have an objective to save 1% of their budget every year in an environment where inflation is running at 8, 9, 10%. So they are hugely challenged to do that, but it's a reality that we have to change. So that means we have to drive efficiency. There's no competition between healthcare providers at the point of care. You go to your local hospital. You don't have a choice unless you're fortunate enough to have private healthcare, which many people do. And change can be viewed as risk, which is fair. Which is fair because we're dealing with people's lives. Accountability is not individual, it's by committee. So you don't have a CEO that's accountable ultimately for the success of their business. You have a number of committees that are responsible for the patient's safety and improving collaboration, including improving ways of working. Now, unfortunately, committees don't have a habit of working particularly quickly or particularly well. Now, I'm sorry if this is upsetting anybody, but it's a reality. Sometimes I can be a little bit blunt. So it's quite controversial. We have a hangover from a blame culture, a very strong blame culture that introduces fear. Now, if you look at a company as an example that failed to innovate, everybody remembers Blackberries, those great handheld devices that were really cutting edge. They put your computer in your hand, in your pocket. What happened to them? They failed to innovate. They failed to see the competition. In 2017, they stopped supporting BlackBerry devices, and they had to switch their business model to cybersecurity. That's a huge change for an organization. So just going back to the pain point again, a never event. It's probably the ultimate pain point. Now, it's as a pain as a change driver, this is very, very significant. The problem is, when we get to the point of a never event, which our device addresses a particular never event, when you get to a never event, it's too late. Somebody is being harmed. Somebody may have died. And that's too late to do anything about it. So we need to be acting before these things happen. And we're very on side of this as industry. And of course, we make money out of it. Let's not be coy about it. We're in business to make money, but we're also in business. Our business is in business to improve healthcare. Now, pain is interesting. It's something we hear too frequently. Can you come and see us? We've had a never event. We really need to do something about it. It happens all the time. Pretty much every engagement, and we have 120 hospitals in our pipeline, our sales pipeline. A lot of them have been driven by having a never event. The sad reality is, if we don't respond quickly after that never event, the pain fades, it goes away. And by 6 months down the line, everyone's forgotten about it, which is really sad. So what do we do about this? What do you do as a manufacturer? So there's a very nice model by Everett Rogers from 1962, which is the year before I was born, so it's quite old, relatively, which is this graph. It's the adoption of innovation. So what we have to do as a manufacturer, we have to find these people, the innovators, because they're the real change drivers. They're the ones that aren't afraid. They're the ones that want to drive things forward. They're the ones that are willing to put their heads above the parapet and say, actually, we need to do something about this. Problem is they're very small. There's a small number of them. They're very rare, and we can never find them. And they're always very busy, because that's their nature. They're busy people. So this was our perception. And maybe I was a bit naive. Coming from the consumer goods region, area of business to this, I was maybe a bit naive, which is not a bad thing, but you know, we learn. So the perception is fairly straightforward. Our device, patient benefits. It's simple to use. It's safer than the current way. It doesn't need interpretation. It's obvious. It should be simple. That, in my simple brain, was how it should be. And why wasn't it? Well, the reality. Real factors that we observe. So this is our observation, and I'm not suggesting that everybody has the same experience, but these are our observations. So there's the weight of change. What flies in? Habit. So habit is very, very difficult to change. You know, we know that we are dealing with a process, so we are looking at a device that measures pH. The current method of measuring pH to confirm correct placement of an NG tube is pH paper. It's been on the ward for 20 years. So in 20 years, people have just got used to doing the same process over and over again, even if it's inaccurate, even if it's sometimes difficult, even if they can only get an aspirate 60% of the time. They're so comfortable with it, it's easy to do. Look, it's not easy to do, to be fair. It takes half an hour on average, but it's something they're so familiar with. So how do we change habit? And you've only got to look at the example of the tobacco industry. It still exists. Why? Why does the tobacco? Because people have a habit and they can't break it. So we have to change habits. Time and resource. So we've heard today and we've experienced the pandemic was a nightmare for us. We launched our product about 2 days before the first lockdown. So we couldn't get into a hospital for 2 years. And since that point in time, there's been a hangover. There's been another 12 months where people have no bandwidth. It's not their fault. It's not their problem in some respects. They're still trying to put fires out all the time. And in doing so, they don't have the bandwidth. You know, it's difficult for them to actually even contemplate doing something new. And then fear. Fear is a huge driver. We know, and it's understandable, don't get me wrong, we understand it, but does this device work? How do I know it works? What if I get it wrong? What if I can't remember how to use it? All of those things build up in people's mind to make it really, really difficult. So these are the things that we're up against, and it makes change a real problem. So how do we as industry rebalance? Because it is our job to do this. We're not blaming anybody in the healthcare environment. We know the challenges. It's our job to make this happen. So we take that responsibility and we take it very seriously. So what do we need to do? Back to the balance again. Vision. It's really important in any change process. And you know, I'm not a change management expert, but if we create a vision of what life will be after implementation of a new product, and we can make that realistic and compelling, then we have a much greater chance of people understanding why they need to move this forward. The next thing is support. So support, we know from the TriTech study that we did, which is such a valuable piece of work. I can't emphasize how much we learned from that piece of work. If we support properly, if we support well, and we've actually reorganized our business on the back of this, when we do an implementation, we have people with their... How did that come in? Oh, okay. We have people on the ground. We provide somebody to stand by the clinicians as they are using the device. So when we're doing an evaluation, we'll have somebody on site supporting the clinical practitioner who is doing those tests for 2, 3, or 4 weeks. It costs us money, but it helps to provide the bandwidth, the reassurance, all of the things that we know that are absolutely necessary. So support is key. Then there's trust. So we are dealing with people's lives here, so people have to trust. There we go. People have to trust what they're seeing. So we've engaged with people. So engagement at the point of development. We had a team of 8 senior clinicians who were all involved in this particular area of expertise that helped us develop the product. We didn't have a bunch of engineers thinking, what can we sell to somebody? It was, what do the clinicians need? So engagement was absolutely vital. Evidence, having evidence to show that our device is trustworthy. We've got thousands of hours of bench testing. We have a clinical trial. We now have probably 10 or 12 separate evaluations that have been done in various organizations that give the proof that our device is reliable. It's more reliable, significantly more reliable than the current methodology. We also have experience, and we're open and honest. Now, the final one is cost. Now, this is something that we use to create the tipping point. It is not the main event. The reality of it is, though, if a new method of doing something is more expensive than the existing method, even if it's significantly better, there is automatically a barrier to entry. So we have to make sure our health economics work, and that there's actually a benefit from a cost point of view, an efficiency point of view. You know, we are about, I mean, what we do actually reduces bed stays. We have evidence to produce, that we can produce to prove this. It reduces delays to feeding patients. So a patient in our clinical study, they waited on average 4 hours. If they couldn't get an aspirate, they waited on average for 4 hours before they could receive any nutrition. That's a long time, especially if you're ill. The longest one was 72 hours. So, you know, this is just not right for patients. We reduce that very, very significant, so we improve the outcomes for patients. So what is it about again? So it's about this adoption and innovation. It's about us finding the innovators and working with those innovators. And fortunately, there's lots of them in the room today, so hopefully I'll be talking to you. Certainly 2 of you already. So yeah, it's really about us working with academia, with the health boards, with government, to actually show where we can provide this value and then support that value. So what happens if we don't embrace change? There's some really good examples there of people that fail to embrace change. You've probably seen them all before, but you know, it's a really graphic illustration of what happens if we don't move forward. But more positively, what if we do? Improve patient care. You know, our business is about patient safety. The reason we have this invention, which was, as it happens, invented by a Welshman, Sean Thomas, who is still with us in the company. You know, we get better patient outcomes. We improve the span and quality of life. We improve safety. We improve efficiency. I'm not just talking about NG Pod at this stage. I'm talking about innovation in general. You know, we have the efficiency drivers. We're talking about the pressure that's going to be on the health service, the aging population. Fortunately, it was in one of the first speakers' talks that we have to drive efficiency, otherwise it just will fall over. And improve working environment. So this is our colleagues. The stress involved in getting something wrong is enormous. If we can reduce that or remove it, we're creating a much better, less stressful environment for our colleagues. So how do we make change easier? So this is a very one-slide change management process for you. So hopefully you'll take it away. So reframing your mindset. This is, you know, seeing change as an opportunity rather than a threat. Really difficult to do. Very easy to say, but very difficult to do. So finding ways to move from uncertainty to certainty. This is where the evidence comes in. This is where peer-to-peer discussion comes in. Expanding comfort zones, like me standing here is expanding my comfort zone. Thank you, Professor Chris, for inviting me. It's not what I normally do, but there you go. Seeking support. You know, there's people that are there to help support, to drive. You know, they want things to happen. And that support comes from an organization, comes from colleagues, comes from industry. Use it. And do it in small steps. Big leaps are very difficult to do. Small steps are much easier. So do it step by step, pace by pace, and you'll get to the end, you'll get to the top of the mountain. And then by making change a habit, get used to change. Get an organization used to change. Get them open to change. Thank you. I would love to know how we can do this better, because it is very slow, quite painful, but we have something that's very worthwhile that should be being used. I would love to know from you what your ideas would be. So thank you very much.
Thank you, John. I should have noted actually in John's bio, it says he started his first business when he was 23. So about 5 or 6 years ago, was it, John? No. But the key thing from John's bio is the fact that it's progression, it's innovation, it's challenge, it's not being settled with the status quo. basically your presentation, which I thought was very good. Although I did make the mistake of checking out what some definitions of pain and how people respond to pain. Anxiety, headaches, stress. I'm feeling it already. Our next speaker has come a long way, and I won't embarrass her too much, but I will embarrass her a little bit. So Anna-Marie Saarinen, Chief Executive Officer and co-founder of Bloom Standard Incorporated. I'll just read some of Anna-Marie's appointments. Appointed by the US Secretary of Health and Human Services under the Obama administration to the Federal Advisory Committee on Heritable Disorders in Newborns and Children. Anna-Marie also serves on the Every Breath Counts Coalition, the World Health Organization Medical Device Technical Series work group, the WHO MNCAH Research Network on COVID-19 in children, the board of the Pediatric Device Innovation Consortium, and is co-chair of the Newborn Foundation Research Collaborative. But I'd say to top that off, she's a very proud mum as well. So Anna-Marie, please come to the microphone.
Good morning. Bwrdd. It's bad, isn't it? I'm working on it. Thank you for that very kind introduction. Yes, it is embarrassing. So if I got a flush in my cheeks, it's because of that and potentially just lack of sleep and, you know, rolling off the airplane and getting on the train. And what a great talk to follow, in a good and bad way, right? I don't know about my slides, just know I sent them en route, so thank you, technical team, but there could be just a few messy things there. I've just come from the Grand Challenges annual meeting in Senegal. I went home for a week, so my children are yelling at me about leaving again. You know, what an inspiration to apply this global health lens to all of the ideas being shared already here this morning. And I actually made a note here because I didn't have a slide on it actually, but I met the director of the Africa CDC, and he mentioned in his talk that even when you have a product, you're halfway to having a solution. I don't know if it's his quote or someone else's, but it's quite good, isn't it, that we're all facing the same challenge. And it truly is about my favorite buzz term, implementation science. And implementation science has to cover all of it, all of it. You don't get to just be a great product person or a good CEO. You have to be a lobbyist and a diplomat and an advocate. All of those things matter. Without it, you don't have trust, and without it, all of the amazing work happening here can't see the light of day. So thank you, by the way, to Sean and Chris and Ian. I think Emma Reese from Swansea is probably here, so somewhere. Hello. Really, one other thing on definitions. I use the term colleague very sparsely, because to me, colleague means something more than collaborator. It means you've reached a stage that you have a real trust fabric and what I would refer to as friendship. And I'm grateful that so many people in this room, after just less than 2 years' time of Bloom Standard expanding into this ecosystem in the UK and having a headquarters here in Wales, that there are many people in this room that I can now call colleagues, and I'm very grateful for that. Okay, so for who doesn't have a little bit of a background on the foundations of Bloom Standard and the Newborn Foundation, really, my NGO work prior, this is my daughter, Eve, and she was diagnosed in heart failure at 3 days old, but completely asymptomatically. So we were to be sent home from the hospital with a baby that we thought was perfectly healthy that wouldn't have survived to her 1 week wild child visit. So if that isn't motivation, I'm not sure what is, because she still was able to somehow persevere for those very critical first weeks and months but really only because we're lucky enough to have access to a few critical diagnostic tools, a couple really smart nurses and frontline care pediatricians, and then of course the team that rallied around her at 4 different institutions to save her life as the youngest baby probably on the planet to have a heart ablation at the time and then survive an open heart surgery. So that led to a really interesting journey for me. I was already working in health tech and med tech. I'd already done some public health research, and I'm a health economist by background, but this is a space that was very near and dear to me, especially pediatric and rural medicine. So when I had this really profound personal experience with my daughter, I kind of leaned all in on like, what can we do as a community to advance earlier diagnosis of conditions that now have a solution, treatment, cure, pathway, whatever that may be, but we're not finding the conditions soon enough, or we're not appropriately diagnosing them. So in the newborn screening vernacular, we call this the diagnostic odyssey, right? There might be something a little bit off, but then parents are bumping around to here and there and everywhere before they can really find out what's wrong. And since you mentioned the Newborn Screening Committee, I also serve on my own state of Minnesota, the Minnesota Department of Health Newborn Screening Committee, and we meet twice a year. And yesterday was one of those days. So I was actually on the Zoom call till 10 p.m. last night, and I'm proud to say the state of Minnesota is now the first state in the country and the first place on the planet to implement universal screening for Duchenne muscular dystrophy. I say that because it took a lot of evidence and a lot of advocacy to get there. And Minnesota is known as sort of an early adopter on a lot of these conditions. But Minnesota was also an early adopter on newborn heart screening. And today, every baby in the United States gets a newborn heart screen before they leave the hospital. Most babies in the UK get that, but it's not yet required here. And in about 50 other countries, they've either implemented this as a standard of care or are in the process of implementing it across their population of newborns. That uses a pulse oximeter, which tells us only babies are hypoxic. The problem was, in my view, in the United States and elsewhere, that we didn't have the imaging tests that could confirm or rule out a true cardiac pathology. And we're talking about maybe 30 to 40% of infants that have murmurs that are otherwise assumed to be benign in most cases and not ordered for echocardiography or ultrasound of the heart. And this was a real problem because babies are not born in the places where this equipment exists or the technicians to use that equipment are stationed. That's true around the world. So Bloom Standards sprouted out of this sort of unmet need, which seemed acute in my own country, was certainly acute in the UK because I was working with the newborn screening folks here 12 years ago on this very issue, and is whatever the word is for beyond acute in the rest of the world. The global south, any low and middle income country you can point to on the map, of which there are many, actually, 80% of the countries around the world. And so we approached this unmet need by looking at what was already in the innovation ecosystem. Is there a way we could work backwards from solutions that were already there? So some handheld ultrasound was already coming out at that stage. Certainly transducers that could plug into laptops. What if we just got more of those out there and did more and more training? Would that solve the problem? But really, it was an image acquisition issue. Even if you donated all this equipment, it took a lot of skill, particularly to image young, tiny patients. So we tried to tackle this from both sides. Yes, AI. A lot can be done with images that are already being captured on these devices that are currently in play. But what about image acquisition? Could we automate it through a sort of self-driving transducer? And so we needed to go from this equipment on one side of the slide. That is what my daughter is seen with when she goes to the hospital. Like, it's really expensive, folks, and it's really big, to something that's really tiny, super intuitive to use, and serves not as the diagnostic for a 45-minute echo scan done by a truly well-trained technician or clinician, but a diagnostic aid for those on the front line of care, and you've heard that many times already this morning, bringing these tools to earlier in the patient stream. I don't know if these videos will play. I don't really know how to do it. Do you think so? I think they're quite short, and I feel like I've talked a lot already. So I wanted to bring you into the settings where my team works and where we're designing our technology for, and then how we kind of are using this backward approach of designing it for the most resource-poor settings, which in most cases makes it super convenient for the places that actually have higher resources, but bringing it out to rural and frontline care. If these don't work, that's fine, but we can try it. Shall I just? Oh, it does. Okay, so we thought before was no echo. So the regular pediatric ward doesn't have an echo. So they have a 20-year-old echo machine that they can move around here in pediatric emergency intake. And then they have about a 15-year-old echo machine up in the NICU, which is better than what most places have, to be fair. But generally speaking, those units they're going to stay pretty stationary here. So for a hospital this size with 3,000 beds, it's not going to address the capacity issues. But for a study, it's good that they have these two machines. Okay, so it was a little bit hard to hear in the beginning. So I think what I was saying there is we're walking into this room at the second largest public hospital in India. They have two functioning echo machines, semi-functioning, one functioning, one semi-functioning echo machine in the hospital. This hospital is a 8,000 bed facility, takes care of the newborns, the peds, the critically ill babies as well. And the fact that they have one is a step up for most of the rest of the places that see children in this part of the world. And so we further went into, and I wanted to shut off my phone because we're going into their version of an echo lab. But you know, this was my first opportunity to bring my engineers into a low resource clinical setting. Prior to this, they had been doing all of the development work and co-development work in higher resource settings, which is very normal for product development, right? This is how we do things, is at the tertiary level, and then you sort of work your way backwards. Two reasons for that. One, that's your patient population is there to get the data, and then two, you have to be able to have kind of those critical stakeholders at that level buying into your technology. Goes to the point said earlier, but this is where words matter when you're working on products pre-deployment. In the global health world, there was a lot of terminology around task shifting, and I think that is not very well received among cardiologists, neonatologists, radiologists, right? It's task sharing. We're trying to not only ease their workflow, ease their burden, but get kids to them at the right time. They are every bit as needed. There's nothing that's going to take away from their burden of patient load. It's just getting the right patients to them at the right time. So this task sharing idea versus, oh, we're coming in and we're trying to take something away from you is pretty important. This is the same hospital. So this is our actually our V2 prototype. So it looks a bit different today than it did before. That was being seen in outpatient clinic that day. We saw I can't do it from this angle. 8 patients. I think that first day. This is the chief of pediatrics and one of the lead research pediatricians that's trying to just get some basic views. We were looking at that point at an apical 4-chamber view of the heart and a subcostal view of the heart, which are the two best windows for early, the simplest interpretation of what's going on with a cardiac, potential cardiac patient. These were all non-cardiac patients, by the way, but we're just trying to see them going through intake. I'll tell you, one of the children we saw that day, I don't have that slide in here today, but she was a 3-year-old that was in the hospital for diarrhea, and we happened to have her consented into workflow that day, and she was diagnosed with multiple ASDs and VSDs, which are essentially holes in the heart. She would have been sent home on diarrhea medication. Instead, she was scheduled for surgery within the next 2 weeks, and she's alive today because of that lucky find as part of our screening group.
Okay, morning of today we're moving really fast. We're seeing babies that are very tiny and quite sick, and so our sense of frequency is going to need to get bumped up a little bit if we intend to do babies under, I'd say like under 3 kilos. It's going to be brutal. Probably not our first target anyway, but it sure would be nice to make sure we have that option kind of moving forward to be able to screen the smaller babies with the cardiography. So that's some really good feedback on form factor and capability to particularly get a subcostal view, which is one we know that we'd like to get, but the long axis, short axis, and apical view, I'm still looking for, especially on the ones that are above 2.5 kilos. So moving to the pediatric ward right now from the NICU, and we'll get a couple of children in 2 months. Check it out.
Okay, that also sounded really murky, but essentially I was trying to explain, and I do these recordings as much for my internal team as any external use, so they can hear like what I've really just walked out of a unit and heard from the doctors, because I don't tend to record as much when I'm right in there, because I'm actively listening and taking notes. But basically what we were seeing in the NICU, because there were several premature babies, as one might expect in the NICU, that our sensors were not performing as well on babies under 37 or 38 weeks gestation. So under 3 kilos to 0.8 kilos or so. So this was a challenge for my engineering team to say, okay, look, what are we gonna do with our chip-based sensors to optimize for this, because there's no universe where we deploy our technology into a setting like this in Delhi or elsewhere in India where it's not gonna be used off-label. That is a fact. Nothing is gonna change that, especially in LMICs. And so we need to account for it, because it's gonna be used on those little kids, and if all we get is a murky mess, then we're not really helping anyone. Okay, thanks for bearing with me while I showed a few of those, so I'm gonna move pretty quickly from here on out. Get on the business side of things, look, okay, I am not a CEO by nature. This is, I'm sort of an unlikely CEO, but I love being a CEO, because I'm not an engineer. So I get to go to my engineers and my clinical scientists and researchers and ask for the impossible and do it with a smile on my face. Like, you can do that in a week, right? And they really can't really even get angry with me for asking, because I can just play the, like, I'm not an engineer, I don't know any better. I don't know how long I can stretch that out, but I'm just gonna keep kind of rolling with it for right now. But we're raising funds, right? Non-dilutive funds, and then you get into this other capital raising world, and there's nothing a true blue Midwesterner hates more than raising money. We hate asking for money. We almost hate asking for help. Fortunately, I'm a lobbyist, so I'm a little bit okay. Like, I can go in front of Congress and ask for stuff, and I'm okay with that. But, you know, asking for financial resources is really hard, and I've had to, it's a quality that I have to work on every day, because I realize it's part of the game. It's part of what we have to do to make sure we don't end up in one of those valleys of death and not be able to get out of it. And so I show you this slide because for the last 2 years or so, since we started raising any outside capital that's not non-dilutive or grant-based, we get asked the question like, well, what's the ultrasound market? How big is that market globally? It's quite big, actually. But that's the wrong question, because we're not trying to compete with Philips or GE. or what's the known ultrasound market, right? We're trying to get into primary care. We're trying to get into all the places where ultrasound is currently not sold nor evaluated as a market opportunity. And so I created, with the help of a couple of my advisors from Medtronic in the US, this sort of slide, which is not very pretty, but I'm trying to get my outside people that are new to Bloom Standard, their heads around this idea that traditional ultrasound is part of it, but it's more about POCUS, and it's more about the AI potential, right? Like, these are all markets that are converging around new technologies that can leverage unique and simple and low-cost ways to do imaging on the front lines of care with a software overlay. This is just a quick shot of I wish I had a prototype with me in a way, because it'd be fun to show people who come up afterwards. But in true startup fashion, all the prototypes we have are in clinical studies right now in different parts of the world. And in November, we will be putting out 4 more prototypes, which is a huge thing for us. It's expensive. You know, they each cost more than they should, but this is the world you live in when you're going from, you know, where you are, which is proof of concept, feasibility, validation, into that pre-commercialization stage. But our sensor, I wanted to show you that one because those little dots on that chip, each of them are a beating drum of ultrasound. We can't program each of those tiny dots, but we can program them as the lines, like, right? Think of them as pearls on a string in a way. And that gives us a lot of forgiveness. That's what allows this type of ultrasound to serve an sort of frontline and unskilled in ultrasound population to be able to work with patients in a way that traditional piezoelectric crystal technology, which is in all the ultrasound machines you see now, is kind of unable to do. And then on the AI and imaging side of things, so we have a hardware solution and a software solution. Those are 2 different regulatory pathways. They will be here as well, just like they are with the FDA. But each are important, and we can't really deploy into resource-poor settings until this AI clinical decision support software piece is validated and on board. Because if we deploy into those settings, and we expect the machine to tell a frontline user whether a heart or a lung is normal or abnormal, and they can't trust that answer, meaning they refer a bunch of kids that really have nothing wrong with them, or worse yet, they don't refer a kid that has something wrong, then we've got a problem. And you'll immediately undercut your whole business proposition, especially when you're a business-to-government solution in the case of these countries. So we came here having done kind of our market entry plan into these different regions around the world. And I just wanted to give you this timeline about when we landed sort of in the UK and set up our partnership in Wales with the Institute of Life Sciences. And I think from here is when I started mapping out like all the acronyms for Welsh partners and learning what each of those like letters meant. Fortunately, I know almost all of them now, which is amazing. And it's good to see so many faces from the organizations who have gone on to become critical partners. And also, coincidentally, that Bloom Standard has one of our core engineering offices is at Texas Medical Center in Houston, which has a biobridge to Swansea, which is like, again, I didn't even know that till we went down to Texas Medical Center. They're like, oh, you're at Swansea, we have a biobridge. And I'm like, oh man, that's a small world moment. But we can all, I think this ecosystem ought to be very, very proud of what they're able to do with a startup coming from another part of the world to establish their European presence here in Wales. It's quite remarkable. And I've shared this example with our own kind of med tech ecosystem in the Twin Cities, which is very heavily medical device and cardiac. And we have like a Medi-Wales in the US called Medical Alley. And I keep telling them, I'm like, you guys can do better. Like Wales has got it dialed in. And so this is our sort of global health map of where we're working right now. And as you can see, Wales is there on the map. Okay, so this is where we're gonna get real. This project we wanna do with Swansea. It's a 2-phase project, which will which will be here and then also in Cardiff. We're almost a full year from originally kind of scoping this out and then having some support from Accelerate. And so I'm here to learn, actually, more than I am here to speak, because I don't think the clinical partners we have at Swansea or my team thought a year later we wouldn't have moved quite as far, at least on this piece of it, than we have. And there are a number of reasons, learning curve, administrative burden, like there's just a lot to it, right? But I am telling you, we would be nowhere without the support that we've had, but we have a long way to go. And after, sometime during lunch today, I'm gonna have a talk with Chris and Emma and the team about, like, there's a balance between being aspirational and being realistic. So, Chris, because we were like, yeah, we're gonna do this IDAP thing, right? This regulatory, like it's gonna speed us along, and we learned about it when they did the very first pilot. So we thought we could take some of our documentation that we've done for our MHRA, for our medical device, and just flip it over to like, oh, we'll do this IDAP application. And then I've got my team in Hong Kong telling me like, we're not ready. We're missing like 3 key pieces. There's no way we can submit for it. And I'm like, look, I got Mr. Aspiration over here, says 100% Bloom Standards ready, we need to do this, and it's gonna smooth our pathway in all the ways that sort of matter. And I got my team being like nervous. They're like, no, these 3 things are missing. So this is where, you know, these tools are available, but if you can't be realistic about whether you can tick the boxes, and because we're resource limited, right? We can only do what we can do. And so these are the tools that we've been sort of looking at in Wales, right? They cover the gamut of hardware development, co-development, the interoperability piece. Can we send images remotely into the hospital for review so that we can refer patients versus doing that online on-board clinical decision support with AI? And then my dream is to do a global health pilot here with the team that we already have in place. And I think we'll get very close to that once we get going at Singleton and Cardiff. Okay, oops, did I bump ahead? Okay, so these are just like a few little, because I'd be wrong if I didn't highlight like all the cool things we get to do in Wales and UK with the partners here since we've been here. And that was an Accelerate event from last fall, and then last spring, our COO, Jake, got to do BioWales in London, which was really cool. And then when I was here in the summer, the Welsh government did a really nice video feature. So if you go to Trade and Invest Wales, there's a super nice video there. I look terrible in it, but I'm just like, but it's, I mean, I'd be like, I'm not showing a picture of that. I look terrible in that video, but it's a great video. And I'm thankful to the Welsh government for sort of fostering us and mentoring us along the way. These are the 5 things that we're working on here and in our remote offices. So we've got hardware engineers now in 3 locations around the world. We want to have hardware engineers here in Wales, and so I hope that by early of next year that we can lean into some of those resources and actually start growing our team on the ground here in Wales as we move towards manufacturing. I know it's probably pretty hard to see that, but I had to put together this snapshot here of our current clinical investigations. This was submitted to the FDA as part of our breakthrough device designation package. That went in September, and so by US FDA standards, the clock starts ticking. We should know within about 60 days whether or not our breakthrough device designation is going to be granted and that they agree with our predicate pathway for our 510K. And in the US then, what's the equivalent to 510K with MHRA? Is there, it's a class 2? MDR, okay. So, so that is closer to a 5 to 6 month timeline. So sometime in 2024, right now, the plan is that we can get FDA clearance on our hardware first technology while we keep optimizing our machine learning algorithms to get that software submission in. I shared this probably, I don't know, less than a year ago. This was just me doing a little bit of digging on the Wales ecosystem. And I think what I'm trying to show here with these tiny dots is that of these hospital and delivery sites, the places where babies are born and seen for care, really only about 5 of them have any ability to do in-house echocardiography and have a technician that's skilled to do pediatric echocardiography or ultrasound imaging. And this isn't like why isn't there more capacity in Wales? This is normal. This is the same situation I have in my home state of Minnesota. So bringing, again, task sharing, bringing a primary care ultrasound out into the field in a way where we can do simple 3-minute scans that can tell us whether we need to refer that child onward or not is really our mission with the clinical validation work we're doing right now. These are just our patient cohorts moving forward. This was all 2023 data, so obviously now we're in Q4. We are about 100 patients off the mark for Q3 right now, so we have about almost 300 patients worth of data as of last week. Almost all of those patients are newborns. We do have some patients going up to age 2, but almost all are in the first week of life. And then data will be driving additional regulatory submissions going into the end of this year and early of next year. This is also a slide I developed for an earlier presentation, I think this summer when I was over at Singleton campus. We have an obligation. We've invested a lot as a company in time and resources and commitment to developing this team and these partnerships on the ground here in Wales. We have a lot more to do, but anything on this list that ends up being like putting a line through it because it's not working out, I would as CEO consider it a bit of a failure. So last time I was here, I went around to tour some manufacturing sites. What can we do even if we're getting our chips are being supplied from a company out of the Netherlands that you probably are familiar with. And then our boards, our custom boards, are in the US. So can we still do manufacturing assembly here? There was a reason this made sense for us in terms of both our European deployment and our deployment into Asia Pacific. And so all of these are so far, nothing's been checked off the list. All these partnerships are intact. But having a new fully funded PhD at Swansea is an exciting breakthrough, and she's here. Yay, nice, thanks, Megan. And she's gonna be busy, like really busy, so buckle up because you're gonna have a lot of fun. Okay, so the rest of these are just sort of images, I think, to close it out for me. This was this is probably our 4th scientific poster session. We are submitting our first manuscript in December on early data collection. I think this is the first time we have seen a paper published that's demonstrating the correlation between hypoxemia, so pulse oximetry values, and an abnormal finding on echocardiography, all under the premise of rapid scanning, single view, single placement, which is the whole like holy grail for us is our users don't have to move the probe around. They just place it, hit a start button, and the scan tells us whether we have something normal versus abnormal. So this was really exciting, partly because I got to share it at Grand Challenges in front of people I really trust and respect, and that Mr. Gates stopped by my poster session, which was kind of cool. He stopped by many poster sessions. I would say he's a nerd. Like 3 hours, Bill Gates was in the posters. I'm not kidding. Like he was really like all sorts of, all the questions, which was great to see that. It wasn't just a photo op. And there's real commitment there on the part of global health to advancing medical devices, biotechnology, to provide a meaningful impact in the places in the world that have the greatest need right now. So I think that is all I can share today. I'm going to try this. Diolch. Thank you. Wait, say it for me because it's diolch. Thank you so much. I'm happy to talk to anybody after the session's here, and thanks for inviting me. It was really a pleasure.
Well, I'm just thinking earlier in Anne-Marie's talk about when she used the phrase low resource clinical setting. And I think we've got nothing to complain about in many ways, have we, in terms of the kind of innovation that's been achieved and deployed around the world. Our final speakers to close out this session, I think it's a double act, Sean? Triple act, okay. Okay. Well, if I introduce you, and you introduce the rest. So, leading the next session, the next speaking is Dr. Sean Jenkins, who's Research Director for ATiC, and been with ATiC since its inception, in fact, before its inception, and is now leading the team in Technium 1, just across the sail bridge there, and will be leading the team as it makes its new home in the innovation matrix in the new year. Sean.
Hi, good morning everybody. So first of all, in the interests of true collaboration, this is a three-way session, and myself, Billy and Mark from Swansea Bay. We're going to be talking to you about an initiative that we've developed over the last 12 months called Wales Innovation in Rehabilitation Engineering Network, or WIRE, thanks to Mark's innovative name-calling abilities. A few people have said to me this morning that they're a bit nervy about doing a presentation. It's the first time since COVID. They've just been doing stuff online, or it's the first time they've ever done something in front of an audience like this. I was told that it's always a good idea to try and think that you're talking to somebody you love in the audience, and it kind of puts you at ease and it relaxes you. So today I'm going to be talking to my 8-month-old grandson, Ren, and my 2-month-old granddaughter, Bonnie. So, got a smile for Grampy? They should be watching on the live streaming. So, and obviously you can tell it's about my age range. Yeah, WIRE. So just a brief kind of introduction to ATiC. We've been operating now as a research centre, formerly part of the Accelerate programme, but still working with partners on that programme. And over the last 4 or 5 years, we've worked with a range of different industry partners, third sector partners, and NHS partners. Some of those, since we've transitioned out of the RDF funding, some of those have stayed with us, and we're continuing to work with them and building sort of longer-term collaborative relationships. And it's collaboration and partnership which are really core to the team in ATiC. And during the course of that, we've developed some sort of specialisms, really, and this is just to give you an idea of the kind of things we do. We've got 4 key pillars, ranging from behavior and psychophysiological measurement, movement and physical performance measurement, 3D reality capture, modeling and virtual simulation, 3D design, additive manufacture and prototyping. Sounds like a lot, and it is, and if you want to chat to us later about sort of what those things involve, then please speak to my colleagues and myself. But fundamentally what we do is we're interested in how people interact with things. So they could be medical products, services, systems, or spaces. And all of those pillars of sort of research capabilities and activities let us help people like yourselves develop those technologies, those innovations, in a way which fits people's needs. And that's fundamentally what we do. We're kind of design research driven. So there's a lot of designers, architects, visual artists on the team, but also we've got clinical engineers, human movement specialists, human-computer interaction scientists, and so on. And the collaboration with TriTech has enabled us to kind of overlap and with that clinical expertise in sort of research trials and medical device approval. So it really brings a kind of a balanced approach to undertaking innovation evaluations, which is fundamentally what we do across those sort of those sectors along the bottom there. So during those conversations that we've had over the past few years, we've got to know the rehab engineering units. Started off with Swansea Bay and Dr. Mark Botel and Lorna Tasker, who were our sort of first point of contact, and then extended that to Cardiff and Vale and Colin and his team there, and then up to North Wales more recently with John and Betsy Cadwalder. And what we realised was there's a bit of a challenge. Like anywhere else in the NHS at the moment, there's a bit of a challenge facing those teams in terms of their capacity and their ability to meet the demands on their services. There's also a high degree of creativity and innovation within those teams, but the clinical demand is kind of preventing them putting a lot of their really, really good ideas into action. So we proposed that we build a sort of network to support that. So we were lucky enough to get some funding from the Wales Innovation Network. And over the last 12 months, we've been able to develop that network, and we're going to present to you today some of the sort of initial pilot projects, and my colleague Billy Woods is going to talk about them in a little bit more detail. And then Mark's going to bring you up to date with the project that we're supporting in Swansea Bay University Health Board. But the primary objective of this is for us to bring together academics, industry partners, third sector, and NHS partners, not just within the rehab units, but the broader sort of ecosystem, to try and support innovation in this specific area. And then if we can prove that that works, then start to build this and roll it out across other areas of rehabilitation and other challenges in the community. So we've been working closely over the past sort of 12 months to identify the challenges. So we've been working with the rehab units, we've been working with their leads and their teams to try and understand where the challenges are, what the bottlenecks are in the patient pathway, and how we might start to develop research strategies and innovation strategies to overcome those challenges. So we're in the process of finalizing a white paper, which is based on that activity, lots of interviews, lots of co-creation workshops and things like that, and we're hoping to publish that very, very soon. So, yeah, watch the press on that one. But the underlying reason for this is to actually try and develop sort of clusters of supporting networks throughout Wales that can actually provide services and help some of the innovative ideas that the rehab teams have actually get through into deployment. So, and yes, this will take time, but we've been working sort of in parallel with that, the research we've been doing with on the white paper, and building up some momentum around potential funding opportunities in the future. So we ran some co-creation workshops earlier this year as part of a proposal for a place-based impact accelerator account, which is ERDF funded, EPSRC funded call, which will be coming out again shortly, and we'll be submitting a bid in March next year. And that's bringing together Accelerate partners, so we've got Cardiff Uni, Swansea Uni, Life Science Hub Wales, but also some new partners, so Swansea Metropolitan University, University of South Wales, potentially Aberystwyth and Bangor. So what we're trying to get to do is bring together all of these academic centres, but also bring together some of the industry partners as well in the region, so that there's opportunities then to take some of these innovations, test them out in clinical scenarios, and then quickly develop manufacturing opportunities and deploy those. So it's a really collaborative idea, and we're pushing ahead with this. This is very briefly a kind of summary of where we're at the moment. We've identified some key research objectives to try and meet with this network. And as I said, we'll be working together with all the stakeholders over the coming months to prepare a bid. This is not a complete thing at the moment, and it's going to keep evolving and keep changing, and we need people to get involved and contribute their ideas to this as well and become part of that network. So as well as putting in the funding bid, we're also going to be developing initiatives and other opportunities to build this network, and you're all welcome to get involved in some form, and we'll be putting a call out for more workshops in the not too distant future. But what I'd like to do now is pass over to my colleague Billy, who's going to talk about the pilot projects, and I'll get out of the way.
Brilliant. Thanks, Sean. So, as he's already mentioned, I want to talk through a couple of examples we've got so far of work that we've been able to get involved in as part of this wire network. They are early stages at the moment, so sort of like one of these projects I'm going to mention is something we're more directly involved in, but we just wanted to give examples of how we can and we will be able to add some value into the wider network moving forward. So the first one of these projects come out of the Rehab Engineering Unit in North Wales, so Betsy Health Board. I haven't got pictures from them, unfortunately. They brought down some examples of prosthetic fingers and toes that they can make. Really incredible. I'm not going to be able to do justice to the level of detail of the things that they were making. They were showing us these examples in the lab. They come to visit us in ATiC to show, and they can colour match. They can use various grades of silicon to match different textures and densities. Really, really, really detailed, really clever. They can match it to skin tone, and they can grade the silicone and all sorts to make it really lifelike, so at a distance you wouldn't know it as a prosthetic. The problem with that is they were explaining to us that the process for them making these prosthetic fingers and toes is very time intensive. So the prosthetist, I hope I'm pronouncing that right, was explaining that his process for essentially hand carving these out of silicone can take many days, so it takes a long time, and because it's aesthetic in nature, they don't always get the resources and time they need to make them. So they were telling us that they're kind of doing it as and when they can, really, to help patients out. They really want to be able to support more of these patients more often, but it's hard to argue to get that time on top of their clinical work if it's going to take them several days to kind of make these prosthetics. So while they were visiting the lab, the conversation went on to, would there be a way of rapidly prototyping these fingers and toes so they could do that kind of work a lot faster with a lot less resources, so then they could argue that they're able to help these patients more frequently because they're not using as much of their clinical time. So Nicholas Thatcher and Ian Williams so far have already begun working on this. So they sent us some pictures of some examples they've been making so far. So they talked us through the process that they're already doing in the way that they're producing these prosthetics. And to Nick and Ian are now looking at, you know, what scanning methods can get what level of detail, which kind of 3D printed technologies or materials that they print in can get close to or similar level of detail as what they're already doing in silicon. So this is an ongoing project at the moment, and the end goal would be to be able to say to that team in North Wales, this is how you could do it a lot faster with a lot less time and money, so then they could argue that they can help more of those patients without affecting other clinical duties. Another project that we're involved in, less hands-on but more kind of facilitated at this point. So Dr. Stephanie Wentworth from Cardiff and Vale has previously set up a mobile arm support service for patients that have got muscular dystrophy, motor neurons disease, and other neurological disorders, which has meant that they're unable to use their arms as much for activities of daily living, things like feeding themselves, brushing their teeth, and other activities like that. She's provided a picture from one of the patients she's previously worked with, and this patient's got a couple of arm supports that's attached to a desk. These arm supports can help these patients kind of reach their own mouth, so they can still feed themselves and brush their teeth and things like that. But she was talking to me through the issue that the commercially available devices at the moment aren't always fit for purpose, like they can get them, but there's the range of things on the market isn't very good at the moment. So ideally they'd like something developed that's a much more fit for purpose and fit for these patients and what they need them to do. So moving on from that, and in the spirit of the collaboration and the wire network, and also the symposium, this one that was done last year, so Iterate Design, they're a design consultancy, design firm. They did a talk last year about a mobile arm support, or an arm support anyway, that was being developed, which is that video on the left. And as a result of seeing the talk at that presentation, Stephanie and Colin from Cardiff are now talking to Iterate Design around the prospect of developing a new sort of, either developing this design further or doing something completely new and fit for purpose for this mobile arm support service. So we're joining in at the moment. We're helping develop those conversations. We're exploring ideas around how we help get funding to support that kind of work. And this week and last week, recently been having conversations around putting in for an Innovate UK bid to get some funding to now Iterate Design to actually, bring that a step forward, and then we're going to help implement all of that. So that's two very brief descriptions of projects I'm working on. I'm now going to hand over to Dr. Mark Botel from Swansea to go through his project as well. Thank you.
Thank
you, Billy. Thank you, Sean. I always remember the first time I went into a care home as a young rehab engineer with a nursing colleague. We were there to assess an elderly lady with a pressure ulcer, and she had quite complex posture. She was sitting asymmetry, and she was static. She would be static for many hours, often in that same habitual position. And the problem was, I'd look around the room, and I'd see there were 15, 20 other people in exactly the same sort of problem. They were static. And so this problem of immobility is something that's always struck me. Immobility is the largest risk factor when it comes to pressure ulcers, but as I'm sure you're aware, it's responsible for a lot of other problems as well. And the thing is about a lot of these people, these are the ones that are mobile in the care homes. They're the ones that can get to the lounges. They're not bound to bed. And despite their ability to move, maybe aided or unaided, they are static. Pressure ulcers are avoidable, yet they make up for approximately 4% of the NHS expenditure. So there's huge costs to the health service, health and social care, as well as, I'm sure you can imagine, a huge cost with infection and potential death from these wounds. So we set about recently thinking about how can we change this culture in some small way. The brief was to look at a tracking system to provide early warning of immobility. So just to inform people what's going on in their environment and how they can be aware of immobility. I'm aware that I'm doing this probably perfect timing in this agenda because we've been sat here for at least 2 hours and my 5-minute slot. I will rattle through through this, but I'm sure you're aware you've been moving a lot, but it's not always as simple as that for some people. So it's about us informing, engaging, empowering, a common theme. But as well as us doing something about reducing the amount of pressure ulcers in this sort of setting, we want to improve carer confidence as well as patient experience in general. So we set out with a goal to find out what they want, not just what we thought was important. So a period of discovery to understand, to explore, and to validate our ideas, but to explore what their solutions might be as well. So I won't go into any details here, but a couple of things to pull out is that there's poor engagement from the people themselves, and this is one of the key reasons we wanted to target care homes, because we recognise that that they're not people that wear smartwatches and things like that. So we wanted to look at ways that we could support that environment. And the other thing was that it should be non-disruptive, and we didn't want another alarm going off in an otherwise potentially quite peaceful environment, and that was very important for those that worked there. But we're seeing times of immobility of up to 8 hours from some of the people that we were observing. We also talked to professionals, and a couple of key things from this is that they wanted to make it clear again that an alarm, we don't want to be just providing care when an alarm goes off. So we don't want to be just being responsive. We want to be making sure this is part of an existing culture and not just alarm based. And so we thought about that challenge a little bit further. I'll come on to that. And we want to enhance regular, reliable care for the many. Well, this is a big question, really. Do we do it for the many in that care home, the 15, 20 that we're talking about? Or is this something that's specifically prescribed to an individual that we have recognised is particularly high risk? So a few questions. Like any good engineers, we went and did some technical scoping, and ATiC were involved in this. We had some very common key requirements of the technology. We looked at different approaches to measuring movement. As you can imagine, on the person, a very common Internet of Things type approach, on the seat, or maybe remote and visual, and that's where my initial thoughts were going. But in the end, we honed in on the fact that we wanted to be using sensors on the seat, because that's more closely related to what we're interested in terms of the loading, the posture and the pressure when it comes to seating. Skip over that one. Around this time, met the wonderful Joe at a startup company called SitFit, based in Cardiff area, and they're doing something similar, but with office seating. So watch this space for this technology for those that are sedentary in their office seating for periods of time, giving you information about not just sitting time, but about posture and mobility requirements when you're sat at the desk. So we thought, okay, let's integrate that. Let's get the hardware we can develop our own software that's fit for our application. Let's integrate it with Common Cushion interface. So we've only just in the last few weeks developed a very simple API communicating with cloud and an Android device which will be an always-on display. This is just a proof of concept at this stage, but we're excited to try it in the care homes. This is what it'll somewhat look like. And it's just going to be a background early warning, if you like. This will turn red after 4 hours to indicate that person has been static and not relieved their pressure over 4 hours. And as you can imagine, because we've got those sensors, we want to do more with that as well. We want to spot asymmetry developing and that sort of thing, and gently inform the care environment what's going on. So up next is testing, various ways we want to do that, and ATiC are going to be heavily involved in that. Also, we're looking at sort of options for follow-up funding to take this further. And I just want to say a big thank you to, firstly, Arch, a regional collaboration for health, and Sean Charles and his team there, through which we had a very small slice of Welsh Government funding to have a go at this. They believed in the vision. To say a thank you to Jenny Brady, who for recently throwing in her energy and expertise into this project and helping out with these slides. And of course to ATiC for pulling together this fantastic wire network. And I'm really excited about the bubbling jacuzzi that's created between us all. Thanks.
So I'd just like to say thank you. I won't keep you any longer because I know the coffee's getting cold. But if there's anything we can do to help out with your innovation journey, then please get in touch. We may not have the answers, but I'm sure that somebody in the room or somebody that we know would be able to help you. And that's the most exciting thing about these kinds of initiatives, is it's about the network that's being created. So hopefully you'll do a little bit of networking now over coffee. And how did Grampy do? Hey, got a smile for me? So thank you all. I'll speak to you later. Cheers.
If you can take your seats again in about 15 minutes, that'd be very helpful. We'll try and catch up.
You got some audio? Hi everybody, if you could take your seats, we're about to start the second session. So I'd like to introduce Dallas James. You're okay. No, you're okay. No, I meant the other. Dallas is Programme Lead for Digital Health Ecosystem Wales at the Life Sciences Hub Wales in Cardiff. And Delith and her colleagues are going to talk a little bit about immersive technology. Thank you, Delith.
Well, good morning. It's absolutely fantastic to be here this morning. I think Sean mentioned earlier people talking about doing presentations. I think this is the first in-person presentation I've had to do for a long time. So it's absolutely wonderful to see actual people looking back at me, and not just sort of names on a screen. So fantastic to be here. We've got sort of about an hour or so before lunch to talk about immersive technology, and I'll let my colleagues introduce themselves as they come up. So my name's Dalith James. I think we've heard the digital health ecosystem mentioned this morning. I might rename it now to the Digital Health Jacuzzi Wales, because my role really is about finding out about innovation and those bubbles underneath the water. So I'm going to briefly explain what we do at the Life Science Hub as well. But my role is very much about bringing people and systems together. And I really hate that you've just all been networking, doing all the things that we encourage you to do. And I've asked you to stop doing that and come and listen to me. So I hope that you do carry on with the networking a bit later. But I hope you've heard of the Life Science Hub Wales. It has been mentioned a few times this morning, so I'm really grateful for the shout-outs. We're an arm's-length body of Welsh Government, and we really exist to bring together innovation and collaboration between industry, health, social care and academia. We've got really simple strategic aims, and that's to improve the health and well-being outcomes for people in Wales and improve efficiency and value within Wales, within the health and social care system, and drive that economic business growth and development through jobs. And we do this really by creating connections. We support industry engagement, and we work with health and social care in Wales to understand their challenges and needs. I think one of my most favourite parts of my role is talking to clinicians and the people on the ground to really understand what the barriers and the problems that they're experiencing in doing their day-to-day work, and looking for those solutions and innovations to help support them. And we invite companies and innovators from across Wales, the UK and globally to work with us in Wales. So how do we do it? Well, we convene, we bring together the health, life sciences ecosystem, and we integrate and we support a coherent, coordinated, collaborative approach across our partners. We want to accelerate access to that transformative innovation, and we advocate as well, influencing at a UK level, showcasing excellence and opportunities. I wanted to talk a little bit about the support. We've heard mentioned this morning already some of the barriers and problems that industry experience when trying to get adoption within NHS and social care in Wales. And I wanted to talk a little bit about the services that the Hub can offer to help support with that. So we've got project management services, and we've got project leads at the Hub who can support industry, health, social care and academia with particular collaborative projects, providing that additional bit of support. We heard about the issues that people might have around that administration, having processes in place, but we can help support people to do that. We've got a sector intelligence team that produce market reports and do rapid scans. So if you've got an idea that you want some support with, you've got an issue that really needs that innovative solution, if you could come to us, we can have a look at what's currently available on the market and provide you with a report that lets you know what's currently available. We've got business case development, again through our sector intel team. So if you've got a pilot or a project that you've been working on and you're looking to have that adopted within your health board, we can provide some support to help develop that business case for you. And also we've got funding support. So we've got information about opportunities around funding collaborations, and we can provide support through our funding specialists to help you. If there's a Wales collaborative bid, they can provide feedback on those applications and give advice and support that way. Partnership development and facilitation, and that's my role. I think very much sometimes I'm described as a bit of a matchmaker. I love bringing people together, so I work quite closely with clinicians, find out what their problems are, and then talk to industry, quite often at lots of different events. In the last few weeks, we've taken Widdy's robots to Het and talked about the things that are happening in Wales. And just last week, we took a couple of clinicians with us to the MedTech Global event, which was really exciting because we were able to talk about the things that are happening in Wales and really demonstrate the things that we can do really well. Communication, support and amplification, I'll touch on that just in a second, but we also do signposting. So I think it's very rare where we can go into a meeting and we don't have the opportunity to signpost people on to further support or access to different partners. And then we do have quite a fantastic network. We've got a website which we can monitor the number of clicks onto the website, so we hold a lot of information available to people on there. And we've got things like the case studies of innovation that we've been working with. So for example, I've seen on one of the slides today about Pain Check, a fantastic pilot that we're working with throughout the hub that uses AI and facial recognition technology. So we've got a case study on the website. We've got lots of press releases about the work that we're doing, so it's well worth a visit. We've also got a database of over 3,000 contacts that we send our newsletter out. So if you've got an event or you want some information disseminated, please do come to us and we can pop that onto our newsletters and circulate that. We've got our social media channels, so I don't know if you follow us on Twitter or LinkedIn, bit of a shameless plug there, but please do follow us and see all the different things that we've got happening there. One of the other things that we do is hold some events, and we have a special interest group at the hub around AI technology, which is a well-established group, and it's been running for a couple of years. We've got about 130 clinicians and academics that join us at that particular group. We meet on a quarterly basis virtually, and we talk about Wales-specific projects that are using AI. We talk about regulatory issues, the barriers to establishing projects, etc. But also we invite industry along to that and talk about the art of the possible. So that's quite an exciting way of seeing what's available and talking to industry and finding out about their barriers and what their challenges are to adoption. So that was a bit of a whistle-stop tour of the hub. But my sort of call to action from that is really that I'd really encourage you to get in touch. We love talking to people, finding out the things that you're looking for. I've had many a happy marriage through my sort of matching service, and I'd love that to continue. So please do get in touch and let me know how we can help you. But I'm going to hand over to Hugh now, who's going to talk a little bit more about the sort of collaborative work that we've been undertaking at the hub.
Good morning, everyone, and thank you for inviting me here today. My name is Hugh. I'm a emergency medicine consultant by trade, and I've only just come off nights last night, so I was called out 3 times. I feel like I'm just about caffeinated enough that I should be able to stand up throughout this, but if I do look like I'm lagging a bit, feel free to throw something at me. I also work for Cardiff University, and that's half my other role, where I am Programme Director in Emergency Medicine degree, as well as the acute end of the undergraduate course. And recently we made the Clinical and Innovation Lead for the medical school at Cardiff. But I'm here today to talk to you about the Immersive Technology Special Interest Group, which I'm the chair of, or the first chair of. The thing that I wanted to kind of first bring up is what is our biggest problem? What is our biggest problem in Wales for innovation in this area, particularly in the world of immersive technology? Keeps on skipping ahead, I'm not sure why, sorry. I think it's because we're still working in silos. I know of clinicians who are working on similar projects in different places, in different health boards. We've got people working actually within the same department sometimes that are actually working on very similar projects and don't find out till about 6 months down the line that we've been working in the same area. Even within the HEIs as well, not just between the HEIs across Wales, but also within a particular university, actually within the same college of university, sometimes within the same school of a college of a university, we find out that we're both 6 months or a year down the line in a certain area. And one of the things that we're keen to do with this new group is to start to break down those barriers. So I thought I'd start off just with some lessons learnt from a particular project which I felt broke down some of those barriers before we go on to evaluation and research. And I'm only going to be touching on that because one of our other speakers is talking about that. Then integration, future projects and how not to work in silos, and then how I feel like our immersive technology special interest group, which has been run by HIW and the Wales Life Science Hub, can help. So lessons learnt. We did a project a little while ago. It started around 2.5 years ago, and it was called the Wales Virtual Hospital. And in that, we basically went cap in hand to the Accelerate programme, and we were asking for some money to develop this project. And within this project, they then put us together with their usual suspects, which were St David's University and ATiC, who did a fantastic amount of work for us on evaluation. We also were put in contact with a certain company and the other HEIs that were involved in healthcare education and all of the different health boards. And we thought, really, we're all after the same thing. We're after a similar product that can help us. That product, we initially had £180,000 from EU funding and then Welsh Government funding. The Wales Virtual Hospital is what we came up with in the end, and this is something which we were trying to cut down on some of the problems that we had with other products we were buying in. So first of all, time to create. We had problems with that in terms of sorry, the slides are skipping ahead faster than I can talk through them, and I'm not controlling them, I don't know why. So problems with the time to create. We've had certain products that we spent maybe 14 months trying to create a certain learning event around, and by which time the guidelines we were trying to teach was already out of date. We've also had some problems in terms of access. So access into the student records or into NHS e-learning for Wales. We want to be able to put that data directly from a product directly into those databases. And also access in terms of what we're using, because of course these fantastic XR products, some very fancy ones that you can put on your head, are not fit for purpose for everyone. And we've got to cater to our students and trainees across the board. And it's great that that product will work for 299 out of the year group, but we also got to cater for that one person who can't use it, who feels unwell with it, etc. We also then got to try and distribute that product across many different disciplines across Wales, and that would mean access via an LTI to be able to sign in with your NHS e-learning, your NHS password, or maybe your Bangor University, your Swansea University, or St David's University email and password. And then we also had some problems with the expense of it. So if I was to describe that a £24,000 project is something that only created 16 minutes of content. That's what we paid before. We wanted to be able to reduce that down so that for the health boards, it was zero cost, other than the clinician's time. And of course, because it was zero cost, procurement are then no longer interested. They will sign things off. It's one of the biggest barriers, I think, for immersive technology to get into the health boards and universities, is that final step of getting across the threshold of procurement. So this is what we came up with. Wales Virtual Hospital, free software developed and owned by all the Welsh HEIs and NHS Wales. And I'm not going to go into the product too much because, we were supposed to be having someone to come and talk about it a bit later. But effectively, it's a system where you can create new software. It's a bit like PowerPoint. And then after that, you can deploy that to your learners, and it doesn't matter where they might be. They might be in any part of Wales. It might be that you need to deploy it across multiple devices, but you just do it once. And then you can also analyze what's happening in there as well. So where the students are looking, are they monitor fixated, or are they actually looking at the patient? What their module scores are, what the critical questions are. Perhaps they scored 99% but gave the wrong drug and killed the patient, so obviously they can't pass. But eye tracking software, and of course the most important thing there, being able to push it back into your existing systems. So the things here are all the things that we wanted as clinicians and academics across Wales for this type of software. And it took us 2 years to get there. So we had meetings every Tuesday afternoon, every other Tuesday afternoon with people from multiple health boards. Well, every single health board was represented. Every single HEI with healthcare was represented. And as a result, we now all own part of this. And it's free for use in Wales. But that is I feel, like a good example of breaking down the silos, breaking down the barriers within our healthcare and higher education institutions, and to work collaboratively, the word that's been brought up several times this morning. So moving on to evaluation and research, and I'm just going to touch on this very, very briefly because we have someone to talk about this in a second. But it's no longer, wow. It's no longer good enough, I think, just to say, we have this fantastic idea. We have gone through that with multiple people, 10 people. They all said it was great. We need to have something more robust behind it. We need to have more critical review of that type of technology before we bring it into our healthcare system and our institutions. And to do that, being based within a university, so I'm going to try and go back to this, being based within a university where we can have access to multiple students, where we can have access to a bit of data crunching as well. But it's not all about quantitative data. The thing that seems not to want to show on this slide here is a control arm and an intervention arm where VR was used or not. But actually the more powerful data was brought up from the qualitative data, and that can be done in smaller groups than the 180 that we included. The next thing I want to talk about was integration. All of these systems are great, but unless they integrate into what we already have, they're near enough useless. I can guarantee you that from knowing one of the IT bods within Cardiff University, that if someone came and said, this product is something that we should use, and we would look at it and we go, you know what, yeah, it is. It's very, very good. It's actually educationally sound. If it doesn't integrate with our existing systems and that student data is not pulled through, we're probably not going to be interested in it. And so integration from the get-go is key. So I'm trying to get back to this. But the other thing here is about it being part of supportive technology. So within our institutions currently, if we have a problem with Microsoft Office or getting into our emails or using Learning Central, a learning management platform, or Exerti, or any other type of learning management, e-learning platform, if there's no one there to back you up, that you can ring and say, I've got a big issue with this, I don't know how I can overcome this particular stop that I've got in producing content, then again, it's a huge hurdle. So be able to integrate it and then have support within your IT system so that you've got someone who you can ring or a team of people that can walk you through it is of huge importance too. So future projects, this is just one at Cardiff University, but in fact, you know, there are very similar immersive rooms. It's not all just about the headsets, it's about other types of technology as well. This is being built with the broom still in the corner. This is what's across the way, the fantastic immersive room they got over in St David's University on the other side of the bridge. And this is from some universities in England. But wouldn't it be great if during the next phase of this development that we were to do this together as well? Create software that we can use across Wales, maybe work with companies that means that we can then get that for free and they can sell it to across the border as much as they want. But at least we get to develop it to start off with. The systems being used now are actually are very similar in nearly all the health boards or universities. It's one of three different types of devices that are kind of being pushed out across the different immersive rooms. So actually to develop that technology would be really, really useful. And it's not just about VR. We discussed VR so far. We've discussed immersive rooms so far. It's about augmented reality as well. Some of the fantastic work that Wrexham University have done on overlaying different types of wounds onto patients as well is great. And of course, all of that helps with our simulations, with our education. A lot of the problems that we find at universities and in the health boards is all to do with the set up and set down time. And of course, this cuts it right down. So, how can we go forward with that kind of philosophy of all Wales collaboration going forward in immersive technology? I feel this is the way that we can do it. So I was invited to chair the Life Science Hub Wales and the HIW new group on immersive technology. It's quite a long name, so we call it IMTEG-SIG. We are meeting either quarterly or maybe every 2 months, and we're going to be inviting industry to come along as well. And we certainly will be trying to do that at least twice a year, purely on the basis that the technology in this area is advancing so far, so fast, that if we don't meet every 2 months, then we're going to fall, twice a year, we will fall behind with seeing what tech is available. I think this is a picture of the Life Science Hub, but of course we're trying to make this an all Wales thing. It's not going to be Cardiff-centric, and we'll try to move around. We have clinicians and academics from across all health boards and all HEIs already involved in this group, including ATiC as well. The main thing that I think this group can produce is a repository of projects. We have all worked separately in this area across Wales for a number of years, and there are some fantastic projects that are being completed. But unless you know about them, you could be trying to reinvent the wheel at your university or your health board. And so by having a list of past, present, and future, maybe aspirational projects, all in one national register for XR projects, I think would be the most useful project out of this special interest group. Somewhere where you can go and work out who to connect with for a project that's been already been completed, where to go if you're trying to find current projects that are halfway through being set up and you want to get involved rather than starting again, or maybe, as Delith was talking about before, the matchmaking service of trying to get those companies, funding, and healthcare and academia all together in one place for future projects to be developed. We want this also to be a place where we're going to be able to give some advice, not guidelines, but advice on evaluation and how to ensure that integration with your current systems is baked in from the very beginning of making any product. And that's about it. So our website is being translated, or soon to be translated. It will be up and running soon. And I think I'm now going to be handing over to Rescape, and Simon from Rescape, who's going to be telling us about one of the fantastic products, I think, which is mainly patient-based, and we've got someone else coming in to talk about an education-based one a bit later on. So, thanks very much.
First of all, thanks very much indeed for the opportunity to come. I've been asked to talk about the development of our product and how difficult it is to actually get it integrated into everyday use in healthcare settings. So that's where I am today. Rescape are based in Cardiff. They've been around for about 4.5 years. The origination of the company is that we actually spun out of a media company. So it's a full-service media company. It's the biggest one in Wales. It's called Orchard. And our CEO had actually got interested in immersive technologies from a media perspective. He then went to a TED talk and heard a palliative care consultant speak about the difficulties that patients had in communicating in those very difficult periods. He had a penny drop moment and he thought, actually, we could use immersive technology to help with the problem. So he went and spoke to Prof. Mark Tobert, who was the TED talker. They had a conversation. We did our first piece of pro bono work for Velindre Cancer Centre. And what we were trying to do, the problem they had was that they had lots of patients who weren't turning up for MRI scans. And they weren't turning up because they were absolutely terrified. So the first piece of work we did was that we filmed a virtual tour of Velindre. So we literally pulled up in the car, you saw the car park, saw the reception, walked into reception, met the receptionist, then went into the waiting room. You can't wear it in an MRI scan, but you could hear the MRI scanner, and there was an interview with someone who had just undergone an MRI scan, and they talked them through the experience. And what they found was that if patients could actually experience that before they went to Velindre, they were far more comfortable about going. They found that their DNA rates dropped significantly, so people's anxiety was calmed. They went and had an MRI scan. Obviously, that's great for the patients because they're on an MRI scan, but it's great for the system because we're not wasting MRI slots, which are obviously very, very important. So that was the way the company evolved. It's quite important for me to tell you that because my experience is I've had 25 years of working for pharmaceutical companies. I've only joined in the last 18 months. So previous to that, these were sort of marketing people, creative types who had developed a product and thought, well, we'll just go to the NHS, tell them it works, and everything will be fine. And obviously that wasn't the journey. So what I'd first like to do is thank John for so eloquently describing the difficulties that smaller medtech companies have in trying to go to the NHS, which is a giant leviathan, and get them to embrace these technologies. There are a huge number of hurdles to overcome. I think the difficulty is that quite often the NHS is used to working with giant pharmaceutical companies or giant medtech companies who have enormous budgets. So it's not a difficulty for them to organize a clinical trial, get the necessary evidence to say this works. When it comes to smaller companies, it is really, really difficult. So we, as I said, we're about using immersive technology, and we do that in two ways. We have a therapeutic arm, but we also have a training arm. I'm first of all going to cover the therapeutic arm. We developed the first Class 1 medical device in the UK that utilizes virtual reality, and it's for alleviating anxiety and reducing perception of pain, and it does both of those things. And we've developed it to be able to be deployed in healthcare settings. Excuse me. The product now has been available since Q4 of 2019. Unfortunately, we had the pandemic in between, so similar to John, our progress was halted for a little while hospitals were out of bounds, but we're back on the trail now, and we are very much starting to gain a toehold. We are very, very early in the adoption of this technology, and similar to John, what we have to do is we have to uncover those innovators who are willing to give this a go, who are willing to actually consider that it could be a useful therapy. What is quite interesting is that the evidence base for using virtual reality for pain and anxiety goes back well over 20 years. So this is not as new as many people consider it. What has happened now is that the technology has caught up. so that you can deploy it independently. Previously, you would have to be tethered to computers to have the computer power to do it all. There were lots and lots of barriers. So we've only recently got to a state where we can deploy it independently, and that's why you are now starting to see virtual reality headsets be deployed in healthcare settings to be able to help treat patients. Currently, at the moment, we are in around 80 healthcare environments in the UK, mainly hospital-based, but we're also in some hospices and we're in care homes. If you think about where is pain and anxiety in hospitals and care homes and hospices, or maybe society in general, it is absolutely everywhere. So we see the potential for virtual reality to help a huge number of people is enormous. The beauty of VR is that it's really low risk, it's non-invasive, and it's a really effective intervention. So that thing is a win for patients, a win for clinicians, and a win for the NHS. You know, we've known for a long time that pain is a biopsychosocial problem, and for way too long we've only really treated it with pharmaceuticals. So what this gives us is an opportunity to actually treat the patient holistically, something we've been talking about for a long time but not necessarily doing. But we now have the ability to actually help them to address the psycho and the social side of things as well as just the pharmaceutical for the medicine. All right. As I said, we also have a training arm to the company, and we were actually dragged into the training arm because we'd established ourselves as the experts in virtual reality in healthcare. What we found is that people were coming to us and saying, oh, we'd like to develop some training modules. We're not really sure where to go, so they came to us because we knew the name. And after the third or fourth inquiry, we thought, well, actually, we should probably do this. So we took on board some people who had experts in doing this. We entered a couple of competitive bids, and we won an SBRI project to develop an emergency tracheostomy training module. I think one of the things that separates us from some of the other VR companies out there is that we are very much about VR first. So we will only use virtual reality where there is a benefit to it. We don't do it for everything. There are lots of elements of our training where you can read it on a tablet or on a computer screen. We will only immerse you in virtual reality where there is a benefit to doing that. There is, globally, there's a huge undersupply of healthcare staff. What that means is there is a significant need for more efficient training tools for medical students as well as the new and existing staff. And we believe that virtual reality is going to help to solve this problem. The emergency tracheostomy model that I spoke to you about, we developed that. It's been finessed. We're working with the ALSG, which is Advanced Life Saving Group. They've taken the module on board, and they've actually run a clinical trial for us up in Manchester University. So Dr. Brendan McGrath, who's based in Manchester, has done a clinical trial, and what they did was they took our training module in virtual reality and they compared it to their face-to-face training. Well, what they wanted to do to make it a bit more interesting was to split the VR arm into two. So they did one session where the students would come to one central location, and there would be tutors there to help them use the VR and explain how to do it. And then there was another cohort who did it at home. So basically the headsets got sent to them at home, and they did it independently. So there was no need for them to come in, no need to hire a room. The number of staff required to train was significantly reduced. And what we found in that trial was that all three cohorts got the same learning objectives achieved. So they were equally effective at doing that. What we did find was that when people did it at home, there was a significant saving in the carbon footprint. And obviously with the NHS drive to net zero, that's going to be quite an important motivator going forward. But also they didn't have to hire a room, so the costs were reduced, and also the number of staff required to supervise was significantly reduced. So there is definitely, in our belief, going to be a large role for virtual reality training to play going forward. Currently, we're in the process of developing 7 modules in collaboration with Swansea University. So, you know, to echo what's been said throughout the day, collaboration is absolutely vital. It's really important that we understand what the learning objectives are for that cohort of students. We do that by working with professionals in the field and make sure that all the training we develop is appropriate for the needs that are demonstrated. I think one of the other benefits that people have mentioned is that with virtual reality training, it's incredibly consistent. When you've got a human trainer, you know, we all have good days and bad days, and sometimes you're on top of the world and sometimes you're not quite as good as you want to be. With VR, and it's all recorded, you know that that training is going to be incredibly consistent. So we think that is going to be a vital part of making sure that we can educate and train the next cohort of doctors and nurses and clinicians that we all require. We honestly believe that every patient should have access to immersive therapies, and we believe that every clinician should have access to high quality immersive training. One of the problems, again, I'm going to be echoing what John said earlier, deployment is incredibly important. You know, we're asking people to use a new technology. I'm working with doctors and nurses and play specialists in pediatric hospitals on a really regular basis. And one of their biggest fears is, if we take this on board, who's going to operate it? Is it complicated? Is it likely to break down? If it does break down, who do I phone? What do I do if we're in the middle of a procedure and I've got a screaming child? And all those fears are really well founded. But what we need to do is be able to demonstrate that that's not going to happen. The technology is robust, and the only way that we can actually demonstrate that is to get people to try it. So for us as a really small company with very limited resource, we have to give people a trial. So we have to take our kit and give it to a hospital free of charge and say, have that for 4 weeks. Obviously, we undertake training sessions, so we show them how to use it, but we've got to put that technology in their hands, let them trial it for 4 weeks, and then they will come back and sort of, they will decide that actually, yes, it's really useful, or no, it's not for us. But in order to be able to develop it or to utilize it properly, we've had to develop it so that there is no Wi-Fi requirement. We know across the NHS, the Wi-Fi it's appalling pretty much everywhere, isn't it? It really is. So we've had to develop it to make sure that there is no Wi-Fi requirements for that. The other sort of benefit that we found from doing that is that we don't have to engage with the IT teams in the NHS. So that is a really positive thing. There is no implementation, there is no installation process. It's an independent plug-in and play situation. So it all comes in a case that you can see there. It's on wheels. You can just wheel it in and it works everywhere. What we talked about a few times this morning and what I've heard is about the impact of technologies and what does it actually do. Sometimes we get bogged down in worrying about the implementation process and we've got to do this and we've got to do that and where's the evidence. Actually, when you hear, we did our first feasibility study in an intensive care unit in the Royal Glamorgan Hospital. Kerry Lynch was the consultant anaesthetist who led the trial. And in that feasibility study, what we did was we treated patients in ICU. We also treated family members, because obviously they're incredibly anxious as well. But what we also did was to treat staff. The staff in ICU are also really stressed under huge amounts of pressure. So we treated them as well and gave them the opportunity to utilize this new technology. What we found, not surprisingly, is that it worked across the board. Everyone who was anxious or in pain showed improvements, and it was all done by self-reported outcome measures. The gentleman you can see with the headset on, he was in intensive care unit for a couple of months. He'd gone into organ failure, was in a really bad state. He was having 20 panic attacks every day. He had 2 young children and his wife. It got to the stage where they couldn't come and visit him because it was too upsetting for the family as well. Through using Dr. VR, we got him to reduce the number of panic attacks from about 20 a day down to 2 or 3. It got to a manageable standard. I'm not saying it's a magic wand, but it had a really significant impact on him and on his family being able to actually come and see him. He felt incredibly isolated in intensive care. Calmed him down enough so that the family could come and see him, which was a huge impact. This gentleman then required surgery to amputate a toe, but wasn't well enough to undergo a general anaesthetic. And the only option for him was to have it with a local anaesthetic and with the VR. And he said without the VR, he definitely wouldn't have been able to undergo that operation. This is the sort of the impact that it can have. It's really significant. This young man had to come to a hospital every 4 to 6 weeks to have quite an invasive procedure done. Impacted his life hugely. For a week before the appointment, he would start to say he was feeling unwell, didn't want to go to school, didn't want to engage with anyone else, started to become withdrawn. We have managed to change his perspective on those hospital visits. Now he has to go, there is no option about that. But now when he goes to a hospital, what he's focusing on is, can I beat my highest score? Has anyone caught me up? Am I still going to win? His perception of that hospital visit has changed completely. It used to be, I know I'm going to have a horrible time, people are going to be holding me down, and I'm going to be enduring something really unpleasant. So we have changed his perspective massively. And again, the impact on the family life is huge. His parents are much more relaxed. They don't have all the trouble with having to get into school before. It sounds like a really small thing, but it has a really significant impact out in the real world. And as I said, we treated staff as well at the intensive care units. These are the sort of results that we're seeing. 99% of people who underwent it said they would recommend it to their colleagues. 90% of people felt more relaxed after they did it. Nearly 90% said it actually lifted their mood and it made them feel better. I'm sure you'd agree if there was a drug that came out with these results, we'd be in quite a hurry to get it adopted or get it through the regulatory process. We've got some big projects that are ongoing at the moment. We're looking at how VR can impact an aging society. So there are some problems that we've isolated with elderly patients that we think we can address in VR. One of the big things is movement, so we can definitely use VR to gamify situations to encourage movement, so that's something that we're looking at. But also loneliness is a huge problem for the elderly population, and from our early investigations, being lonely doesn't necessarily mean being on your own. We spoke to lots of people in care homes who were surrounded by people all the time who felt incredibly lonely because they weren't surrounded by like-minded people. So one of the things you can do with VR is you can put people in a virtual room who have similar interests or similar groups. So you could have like a Sunday quiz on certain topics or whatever, bring like-minded people together. So those are the sort of things that we're looking at. We'll just put people in groups and make them feel part of a community, because that's incredibly important. We're also using AI. It seems to be a popular theme. If you're not using AI now, you are definitely falling behind. So we're going to look at using AI and music to try and personalize the spaces that people are inhabiting. We need people to come back to VR and use it on a real regular basis. So the way that we can do that is to make it feel like it's their space. It's somewhere they feel really comfortable. And we think that music is going to be a big part of helping to do that. We're absolutely clear as a company that the evidence base is the way forward. You are going to have to keep building that evidence base. But what we are, our sort of plea to the NHS and to NICE and to the regulatory bodies is to understand we don't have unlimited amounts of money to be able to undertake these massive clinical trials, but we can generate some real-world evidence, and we are really keen to collaborate with anyone who's interested to help generate that. So if there's anyone here who has been listening and their interest has been piqued, or they think there may be a use for them to adopt virtual reality, I would say please get in contact with us. We are very, very keen to collaborate. And thank you very much for your time.
Right. When do you want to do the video? Right at the end? It's going to be easy because we have to sort of jump out of this and then jump onto that stick.
Is that all right if I jump out? Will you be jumping out on it? Will you jump out on it? Yeah. If you can do it now, that'd be great.
Do the video first?
Do the video. Or the presentation. If I can get on there.
Do the video?
It's just like presentation, actually.
Oh, right. So it's a new PowerPoint that we've got.
Sorry.
Okay.
Apologies, I'm being very awkward here.
Right, so on the stack.
There you go.
That's it.
There you go. And then it's just...
Got you.
There you go.
Loading.
There you go. That's perfect. Brilliant, Chair. Thank you very much. Well, good afternoon, ladies and gentlemen. Thank you for having me here today. As you can see, I'm not Robin Davies in your brochures. I'm George Bellwood. I'm his colleague and business partner, but I'm the co-founder and CEO of VTSTech, and I'm here to talk to you a little bit about what VTSTech does, what we've been working on, especially with the Wales Virtual Hospital project, which was a collaboration project between all universities here in Wales and health boards. So this project was pretty much for clinicians and academics coming together to build this e-learning platform tool that we were able to sort of move forward. VTSTech is a no-code virtuality platform that allows organizations to build their own immersive simulations and deploy out to their employees or for their students across any academic or any training facilities. So firstly, obviously, we all know that virtuality is a really hot topic, especially a really useful technology tool. They can be great and come with such amazing stuff, but they do have their limitations. I'm sure a lot of you might have seen this when you come into doing projects. You can have anywhere from very long delivery time for any particular bespoke created ones for you. Simulations can be quite costly sometimes. That's obviously when you want to try and go for grants and everything. You might have a bit of a limited device access to this, so obviously VR headsets, you know, the Rescape, which are doing such amazing work, as they said, they only use VR headsets for the pure reason when you need your students or your employees to be in a VR headset. We have the same sort of philosophy of that one, which is if you need a VR headset, use it, you know, for that immersive side of it, but if you don't, but there's a lot of VR companies that do just focus on that sort of device only. And then non-configurable, so again, if you have a bespoke created simulation for you and you want to make any changes and anything like that, it can become more costs on top, or it can actually be impossible to sort of do. So what is it that is what we really have built? Well, it's called DigiSim, so it comes in sort of 3 pillars here. We allowed the clinicians to be able to create their own simulations using the content that they've recorded in simulation rooms like they would normally do with their students during academic years. They would take that content, put it through the creators mode and be able to sort of drag and drop their simulation content in, so you can bring your own materials in, and then that can be deployed out to the simulation mode. And then the simulation mode is where the trainees and the students will be using the simulation, if you like, and doing the learning through the platform. And then we have our data mode, which then tracks how the students and the trainees have been interacting with the system, and then that's fed straight back to the clinicians and academics, and then they can make any adjustments that they need based on that simulation. So with this sort of solution, we've been able to actually reduce down the delivery time to, we've had some clinicians who have used it with the partners of the Wales Trinity Hostel. Within one day, they've been able to record something in the morning, go into the afternoon, over lunch, create the simulation, and in the afternoon, they deployed it out to their students. They were able to have the ability to create unlimited simulations. So, you know, it could be a case of they wanted to, you know, go from an easy to a hard level for the students to learn as they sort of go through it all. They have the ability to use any device possible. So the simulation mode allows this to be actually accessible on VR headsets, any VR headsets, but also on desktop, mobile, you know, tablet, because as we understand, if you've got a classroom full of 350 students, then you're not going to be going out to buy 350 VR headsets, you know. Yeah, it's very expensive. And then again, fully configurable allows them to go in and put their own materials in. So what we've sort of been seen as is the PowerPoint of VR, if you like, where you can create your simulations and deploy it out. So I've got here just a quick video just to show which of the simulation here. So this was one with Cardiff University that we worked with for the basic life support. As you can see here, this is a time scenario that was created that basically of the new system here that we've updated, and we also worked with ATiC as well, so they did a lot of research into it. You can pop your question in, you can save it, you can edit it all, you can then drag and drop any of your answers into it, or what sort of hotspots you like to go into it, so information hotspots, answers, so correct answer, wrong answer. So it's very much a case where the student will be fully immersed, go around, looking around, clicking on the hotspot, and then the feedback is what key is. So the clinicians can pop in their own personal feedback that they want, and then they can go between different scenes. So they can go from 360 images to 360 video straight from this, you know, the simulation and inside. So again, it just gives the clinicians and the academics the, you know, the power to be able to build their own simulations, personalize it, customize it the best as possible. So again, what it really brings is it goes beyond limitations. It became, you know, being a device agnostic organization brings its huge benefits, especially to things. I can see I've not done a very good job in the middle one there, but it's scalable as well. So again, getting this out to the students as well and making sure that, you know, not only on VR headsets, I know that a couple of universities are having their own immersive rooms that they've got, but they're also getting the VR headsets for students to visit and come and use it, but then scalable to allow them to do this whilst they're at home on their desktops, laptops, and surprisingly, there's a lot of students who are buying VR headsets who can have access. And then frictionless. So what we have created was a very special API that actually connects up with all the major learning management systems. With these learning management systems, it basically means a single sign-on. So it basically means you don't have to create any new accounts and like that. And through the creators mode, as sort of the admin users, you would then have your cluster of different, you know, either students or staff members or anything like that, that you would then allocate a certain simulations that you want them to go through. Through the LTIs or the APIs, the integration here, it also automatically feeds back through the data mode that we've got within the platform. So when students are actually being tested on this academically, all their answers and feedback can be easily piped back into Blackboard or Canvas or Moodle or any of the other learning management systems. So this makes it just a really easy to use, frictionless, as you like, process where you can have it all in one section. It doesn't mean that you have to be clicking on many, many different tabs and everything like that. That's something that, you know, we've been learning during the project for the Wales Trinity Hostel, where academics didn't really want to continuously having to log into different areas to look at, you know, this and then having to export it all out of that. This is something that just does automatically straight through the platform. And as I said, I know I bang on about this with the device agnostic side of it, but we have got the capability of getting it across any device possible. So it doesn't mean if you just have to stick with the one kind of brand. You can do this offline and you can do it online. So there's a lot of questions asked, especially when offline mode, when you have it just purely on the headset. Data can still be tracked on the VR headsets when you're offline. So when you do connect to the internet, the data is just cached in the headset, and then once it's actually uploaded to or connected to the internet, it is then uploaded into the data mode, allowing sort of the academics and clinicians to view how their students have been using this. As I said, we've been working with you know, a bunch of partners here in Wales. It became a very big collaborative project since COVID. I think this is sort of what spawned this, which was clinicians wanted to create and academics wanted to create something, their own personal one. I know there's a lot of universities now that are investing a lot into their media and starting to create different types of media for them to use as part of their sort of modules, if you like. So every health board and university had this as a free sort of offering from Wales Tech, and for the Wales Virtual Hospital project, this is what came out of it. It's free to use for your university, your health board, and for your students. We are looking at creating a marketplace, so this is actually something that's sort of spawned up as a bit of a project. A lot of the universities have obviously been swapping a lot of the media across to each other. Or, for example, if you've got one university that's actually created a simulation, there's no point in having another university creating the exact same one. Instead, they can just take it straight off the university through the agreement that we have on the marketplace through the Wales Virtual Hospital, and then they can customize it themselves, you know, on top of what they want to do, so their learning objectives, their learning outcomes, and everything like that. We're also opening it up to VR companies, so we have a good number of VR companies here in Wales, but also in Canada and in England. As we sort of saw it from one event, there was a Canadian VR company that created a simulation on X-rays, and obviously we had a university learning manager there who said, I would love to have that, because that's definitely something that the students could really benefit from, and it's something we can't even teach or even sort of train on, shall I say. We can only teach them through books and sort of images. So that was created, and so they're now joining onto the marketplace, and this allows sort of the universities and health boards to see what sort of projects that they've got going on and connecting up with them to sort of join alongside with them and sort of tap into that, if you like. And then finally, we've just got some sort of work that we've done outside of Wales. So we had an organisation from CDC, I don't think their logo's come up. So the Centre of Disease Control, we met them out in America. We showed them a little bit what they do. They've got their own sort of virtual reality employees, if you like. They've got about 10, 12 of them, and they build, you know, bespoke simulations for their own establishment. But they've used our stuff because, you know, they found that with the Wales Virtual Hospital as well as other stuff, they were able to build something a lot quicker, deploy it out, and again, a little bit more simpler, you know, a bit simple for them. Doesn't need to be too technical, and then they can get this across. So, you know, again, the learning outcome was 10 times better, and they were able to reduce their development time by a significant amount. So that was a really big sort of plus and positive. So again, we're sort of looking to collaborate with a lot of different VR companies to get them onto the marketplace, and B, to sort of share the knowledge and everything like that. And Wales Virtual Hospital is free to use, so if you're interested at all, please come and speak to me afterwards or anything like that, and I'll be happy to sort of get you signed up and set up. So that's it. Thank you.
So we've got one more speaker for this session. I can see the food's out and everybody's tummy's rumbling, so if you could just bear with us. Delith has suggested that we skip the Q&A session at the end of this, and you can meet up and talk over lunch. So our next speaker is Dr. Mikhail Toombs. Thank you.
Thank you. Okay. Right. I know you're all hungry, so I'll try and be as quick as possible. I'm based at Cardiff University, and I'm based at the Centre for Medical Education. I'm not a technologist, I'm not working in industry, and I'm not here to represent kind of anything that I do at Cardiff University particularly, but the focus of my talk is going to be very much on evaluation, scholarship and pedagogy, and why it's so important that we embed that in what we do. Now, throughout this morning, I heard a lot about deployment and implementation, and how do we convince stakeholders to actually use the technologies. And it's about longevity, it's about sustainability, it's about scalability. How do we convince them to actually take this on, and that it is as good or even better than what they're doing? Now, when we talk about evaluation, we talk about treatment and diagnosis, so using technology for treatment diagnosis, but we also use, and this is the examples we've had in the previous couple of talks, we use technology an awful lot in patient education and also in the training of health profession workforce. And we use a lot of it also in undergraduate courses as well as postgraduate training. And when I prepared for the talk today, I found that there's actually an awful lot of research. There's a large body of evidence that accumulated and done a lot of the work for us that looked at evaluation and the efficacy of this intervention of technology and the use of extended reality in training and also in patients' education. But what they found, and there's a 2023 review there, and they actually synthesized reviews. So they found lots of papers from all over the world around patients' education. And here as well, that's 133 studies that reviewed the efficacy of the use of extended reality in medical education. There's a lot of research out there, but they all have overarching theme. There's kind of a common finding in these reviews. And what they're finding is that we need to do more evaluation and we need to do better evaluation if we really want to be able to implement, to convince those stakeholders to use the technology and to its full potential. So more evaluation, more scholarship, we need to disseminate these findings, because what happens is we don't actually know if we hear, this is a review of the published and some of the stuff in the grey literature. There might be lots and lots of stuff and really good stuff going out there that we don't hear about. And they're calling out for more evaluation and more scholarship, so we'll be able to convince the implementation and deployment of the technologies. So why do we want to do more evaluation? Why do we want to engage in more scholarships? We want to do more evaluation, and this is what they're saying, these researchers, this is a call out from these reviews, is that we want to determine the feasibility of the program prior to its implementation. So we want to be able to convince stakeholders of their value. We also want to see if they were implemented as intended. We want to measure the effect of the program, and what I will show you now, that actually effects of the program, there's more research on that. There's less kind of throughout the program, and also there's less research around the mechanisms that lead to program outcomes. Because if there's anything that we've learned from COVID, and this is the unintended outcome that the pandemic have taught us within educational institutions, is that we want to use more technology, but we really do have to upskill our staff. We have to upskill our students. And in fact, it's actually more expensive than face-to-face teaching. Because if, for example, conferences like this, if we wanted to do it online as well as face-to-face, the amount of resources, the challenges, the things we have to think about, it's just a bit easier to go back to the good old days. Well, not so good, but the old days, because you really do need to invest a lot to maximize its potential. So the difference being is that we have got most of the studies that you find around evaluation of extended reality in healthcare focused on outcome evaluation. And really what they do is they measure the impact. So you decide what you want to teach, and then you measure the impact. And this is versus program evaluation. And program evaluation is the kind of evaluation that we do to try and understand, why is it working? Or why is it not working? What are the challenges that we try to overcome? So a lot of the research we're finding focusing on outcome rather than program evaluation. There's a few there, but not many. So let me show you a bit. I don't know if you can see. So you probably will be familiar with Kirkpatrick model of evaluation, and where the lowest level of evaluation is looking at reaction. Basically, are they enjoying it? So a lot of research has been done at that level, but also at the level of learning. So the kind of post-test, what have they learned? Are they feeling more confidence now, and so on? There are very few studies that look at actual impact and results and behavior. And that's what we want to be able to demonstrate. And it's very difficult. If you run a training course, it's very difficult to actually evaluate impact and results, because there are so many confounding variables. There are so many things that could impact that. And it's very difficult to control that, for the fact that it's just the training, especially when it comes to technology. So it's not surprising that most of the research looks at reaction and learning, and that's absolutely fine. So here's the findings. This is just to show you that the majority of the research around extended reality use within medical education basically look at level 1 and also at level, to some extent, at level 2 as well. So much more that, very, very few looked at behavioral changes, benefits to patients, benefit to clients and families and communities, and very few, actually just one of the studies looked at change in organizational practice and change in professional practice. And this is the kind of stuff we need to be able to evidence if we want to increase the use of extended reality technologies. And here, this is not within the healthcare. This is within the construction safety industry. And it's the kind of stuff, this is just showing that a lot of the evaluation being done is focusing exactly at that reaction and learning level, and not an awful lot looking at behavioral and so on. So this is where looking at objective measures, things around which, like the virtual hospital is measuring the eye tracking, where people are looking, the number of errors that people are making, the decisions, the tick boxes. So there's a lot of that. But actually, a majority of them also looked at questionnaires and interviews of perceptions. Did you enjoy it? Did you like it? Did you feel that it met the learning outcomes, and so on? And what I'm trying to present here is an argument, really, that we need to do more. We can't just focus on the outcome measures. And also, what these studies show us is that the technology provide as good a solution, not necessarily a better solution. But if to do that, stakeholders have to invest an awful lot of resources and money, then we are struggling to convince it to take them on, because it's as good. So why take on if it means that I have to invest an awful lot of resources and time and everything else? So this is where the call is for a more extensive program evaluation, rather than just focusing on outcomes, looking at context, asking patients, asking families, asking educationalists, asking everyone in terms of, are we actually addressing the learner's needs? Is there enough pedagogy in there? Our objectives very clear. Thinking also about the input, the materials, the instructor's method, the physical environment, the equipment, thinking about the process, the teaching, the classroom activities, and then thinking about the product. So they're calling out for more. Now, it is more resource intensive. We understand that, but we need to at least try, if we can't do all of it, to do more of these aspects in the evaluation that we do of these technologies. So final slide. I think I'm talking faster. So evaluation should be considered from the outset. It shouldn't be considered as an afterthought. And this is because there's nothing worse than you've run a hole, you developed something, and at the end you say, oh gosh, if only we could have analytics that will tell us, you know, they did this or they didn't do that. If from the outset you know what you're looking for, you would also already have the analytics collected at the end that you can use for evaluation. And I'm not saying that outcome evaluation is not valuable. It's definitely valuable. It's also easier, so you can understand why it's being done. It's a really useful tool to allow us, you know, to measure effectiveness against preset objectives. But we really do need to think more about program evaluation. But that all thing considered, it is more complex. It does require more resources because it's that kind of qualitative elements within evaluation. But it's more likely to highlight the factors that contribute to these outcomes, which will allow us to convince the stakeholders in terms of implementations and deployment. And a few, if you wanted, if you're interested, I'm an academic, so naturally, you know, I use research and I use references, but if you wanted to read, I kind of went really quickly through them, but these are the papers that I used to build this. So thank you very much. I think it's lunch.
Okay, so thank you everybody, Delis, Hugh, George and Mikhail. Lunch is ready. If we could come back to our seats by 2 o'clock, that would be really good. We can make up a bit of time then. Enjoy the lunch.